So this is going to be a study with me video featuring MBBSFinals. So the thing is, this is my second try. I already did one for about an hour, just 10 minutes back, and I just checked how it is. I just wanted to know how it is going to be like. So this is, hopefully this is going to be better. So what did I do? So I just went through pediatrics for a while from the website, and some sections, not some sections, 2 questions, and it took almost an hour. So I just wanted to see what would be the pacing like and all that. And yeah, so right now this is going to be a real one meaning I'm going to be uploading this on YouTube, and it is going to be in this format, 50 minutes where I would be going through this website and learning the content, and 10 minutes of break where the entire screen would be turning into green based on what this thing shows up. I don't usually use this, but for this particular study with me, I think this is going to be very useful. And then, so 50 minutes of this, 10 minutes of break. Then after the break, repeat this again. I want to see how long it can go. This is going to be day 1 of doing this. And regarding the study content itself, the thing is, the last time I went through this, it was from my textbook, and it was during my model exams, which was, I don't know how long, it was quite some time ago. And the thing is, the headings and all that, though you remember the reasoning behind the things that you learn, there are some things that you skip because of exams. So I have skipped some things, and also in addition to that, even the headings, those are volatile meaning personally for me, like it's very difficult to remember things for really long duration, and that's the case with most of the people, I guess. So in this particular study with me, I'll be going through each and every question, like trying to go line by line as much as I can, and in case I have any doubts, I'll be going through ChatGPT and Google, and in case, and there is this for pediatrics specifically, I'll be using this Arun Babu. This is the book that I've been using since last 1 year, and it is really good in my personal opinion, because the size is small and you can finish it quick, and this is a really good book, our college record book, which contains a good amount of information regarding anthropometry, nutrition and all that. I'll be mainly, in case I don't understand, I want to add up something in this particular to this particular content, because I've told this earlier in the first video that I uploaded, like supplement it with the textbooks. In case you don't want to read the textbooks, okay fine, then you come here, but otherwise I think it's a good habit to go through the textbooks, because textbooks give you everything, but this can be a good alternative, especially for exams. Yeah. So earlier I mentioned I did an hour of study with me by myself. I have the video inside. Should I show it? Yeah, it's here, the raw video. So this is the one. This is, I'll open it. Yeah, it's a 44-minute thing that I did, and I won't be posting it anywhere because yeah, first time it is going to be trash, but I'm used to it now. I'll be repeating the thing, so possibly the first question and the second question we would be going much quicker, much faster, but later on the pacing is going to reduce, the speed is going to reduce, because the first two I know the content, because I've done a study with me and I have understood it, and as I went through the process, I created this Google Doc which has some mnemonics to remember some things from ChatGPT based on this. So some things it is like hardcore memorization, very difficult, so using mnemonics on that side, and so keeping it there, because I can't add it here. This is the main document, main page, so it is going to be on a separate Google Doc, and hopefully if I remember I'll be putting it in the description of this particular video. I don't know how long it is going to be. Like right now it is around how much, 11:56, so almost 12 o'clock at night. So should see how long it goes, and how long I can concentrate and keep doing this, and this will hopefully help me in pacing the rest of the study with me videos in the future. So it is not a regular study with me wherein I am just have the camera here and it is looking at me, and you guys are doing your thing. For example, in case you are studying, no, this is specifically wherein I have the website which I have created in front of me, and I'll be studying using that and supplementing it with the textbooks and all. So, and I'll be as I learn, I'll be teaching it to you, trying to teach it to you or the camera right now or myself, and yeah, and that is how the thing is going to go forward, and should see how long this entire thing is going to take. I doubt I'll be able to finish it today, very low chance, but let's see how far I can go. Then based on that I can decide if it is even possible to do the rest of the papers. I know it is very unlikely to do it to be able to do it, but anyways it's worth trying, because otherwise there's nothing on this particular channel to be uploaded. I can't upload some shorts and all this study related website, YouTube channel. So this is one good thing that I found, and I'm talking. Why is that? I don't know. I'll start studying now. So I'll start the timer, and I'll be going through the first question, and this is going to stop at after an hour, after 50 minutes. Then we are going to take a break, then hopefully coming back. Yes, let's begin. Yeah, so the first one, define growth and development, discuss various factors affecting growth, and mention various methods of growth monitoring, discuss laws of growth in children. So I read it just now, but hey, I know it's hard to remember, but it's fine. Define growth and development. So growth and development, two different meanings. So growth mainly relates to the increase in size of cells, leading to that is one thing, and another thing is growth, increase in the like multiplication, increase in number of cells. So these two lead to increase in the mass of the tissue. So cells increase in number and also the size, and the mass of the tissue increases. That is growth. Development leads, like usually development in human human sense, it is wherein a human is able to do stuff in a human way, like baby is able to move his hands and legs and all that, and so that is the basic meaning. Based on this you can make up, I think like hopefully by the end of this month, it is before university exam, I will be able to get the definitions right in my head, because those are very important. Then discuss various factors affecting growth and factors affecting growth. So there are multiple factors, a lot of them actually, starting from genetic, environmental, social, nutritional, endocrine. That was one more, I can't, infections, I can't remember. Like there was another one, yeah. So under that there are different things you need to write, and then there is methods of growth monitoring. So anthropometry, very important in theory and practicals. Discuss laws of growth. There are some laws which growth follows. So abnormality in the laws equals pathology. So let's go through this each one by one. So growth refers to increase in size or the mass of tissues due to the because of multiplication of cells, and increase in the intracellular content. So size, intracellular content increases, so size increases, multiplication of cells. It is a measure of physical maturation and is quantitatively assessed by measuring body dimensions such as height and weight. So these are the two measurements that are done to measure growth. Development signifies functional maturation of child. So functional maturation, that is the keyword here, and this is physical maturation. It encompasses acquisition of various skills essential for optimal function. So, optimal functioning for human being, doing things like walking, holding things, holding this pen, looking straight. It can be anything. This process is attributed to the myelination of nervous system. Yeah, that was the thing that I forgot to mention. Myelination of nervous system, keyword Schwann cells and all of those, very important. So that is key point in development, and it is evaluated by assessing various functions. So different functions, and in the case of pediatrics, there is something in practicals, developmental milestones, which assess the myelination and functional maturation. So it makes it clear. Factors affecting growth. So as I mentioned earlier, there is genetic, environmental, social, endocrine, nutritional, and other factors. So first one, genetic factors. Phenotype meaning, so P for phenotype, P for parental traits, PP. So determine genetic potential. Race, different racial groups exhibit different growth potential. So Caucasian, Africans, Indians, Asians all have different kinds of growth patterns, growth potentials. Sex, boys tend to be larger than girls at birth. However, girls experience an earlier growth spurt. So boys are bigger in size when they are born, but girls experience earlier growth spurt. So there are some memes and all going on, which are related to this, I guess. The second part. These are related to second part. Biorhythm and maturation. Girls reach menarche around the same time as their mothers, so it is genetic based. The genetic disorders, Turner syndrome, Down syndrome, these affect the growth patterns. Environmental factors. This is prenatal, postnatal. So we are talking about pediatrics here. So prenatal, before the child is born; postnatal, after the child is born. So prenatal, this comes in the obstetrics section. So maternal malnutrition, infections, tobacco, alcohol consumption. So smoking and alcohol, infections and malnutrition, in case of mother, can lead to the fetus having retarded growth. Pregnancy related complications such as preeclampsia and multiple gestations impacting growth. So few points from OBG, if you remember, you can like blast it here in the prenatal section. Postnatal, neonatal hypoxia, convulsions may cause brain damage. Neonatal hypoxia, convulsions. So cause could be anything. Could be because of intranatal causes leading to neonatal hypoxia. So this could be attributed to the previous one itself, but since it's a separate specific term, it is included in postnatal section. Malnutrition. So the thing is, one break. I just want to mention that me as a student studying this is different from a teacher teaching you this. So a teacher is much more knowledgeable. He is an subject expert and he knows everything about it. But me as a student, I am learning all the subjects, and this is before the exams, where I am trying to the content is here. I am trying to put it inside my head, and so that I can bring it out during exams. So in case you would like to get proper expert guidance and learn it properly from a teacher, better do it from a teacher rather than learning it from me. So but this whatever the content is here, this is for the exam specifically. So specifically, if you want to learn and put it inside your, like, learn it meaning learning regularly, it happens throughout the course of 4 years in MBBS. So if you expect that to happen here, that is not going to happen. So you need to keep that in mind. Portions and all that very important. Can't just expect that thing to be done compressed within 1 month of preparation. Coming back, postnatal. So I went from here to there, because there are so many things that you can connect from there to there, to here to there, and everywhere. Social factors. There are multiple socio-economic status, poverty, climate, emotion. So affluent. So affluence. So how much money does he have? A lot of money. The person can become obese, the baby, the child, and no money, it is undernutrition. And then undernutrition, less money equals undernutrition. It also equals infections because less of hygiene. so less food and all that, and all of it can hinder growth. So everything over here in the low economic status, everything can hinder growth. But poverty, affluent backgrounds, obesity. So that is overnutrition. That is a bad thing there. Climate, growth rates are higher in spring and lower in summer. I want to copy this and put it in the Google and just search why that is the case, but I don't want to do, because simply it's going to take too much of time, and yeah, I think I should do it. Yeah, so copy this, no, not in Google, to do it in ChatGPT. Yeah, paste y. Hormonal, okay, seasonal hormonal variation and also behavioral and the physical factors that are involved. Yes, makes sense. Okay, fine. Actually, it didn't make sense. You need to go more in depth to actually understand this point. Emotional factors. Children from broken homes or orphanages may experience stunted growth due to anxiety and lack of emotional support. Yeah, anxiety, like you have more of, this could be tied into that, what is it, the endocrine section, wherein you have more of cortisol and all that, and a lot of cortisol not good for your growth, very bad. Lack of emotional support, yeah, I don't know how that is tied in, like there is a tie-in, like most of these emotionals, these are tie-ins with endocrine and neural. So endocrine mostly, in like in case you are looking at growth specifically. And there is endocrine. Endocrine is vital for growth and development. There is growth hormone, thyroxine, androgen, insulin. So growth hormone specifically, it's obvious, it is there in the name, thyroxine. So less of T3 T4 cretinism, like hypothyroidism in the baby, you can there is a less of neuronal development, brain maturation is impaired. Androgens, like sexual maturity, that is impaired. Insulin, remember the term, like insulin like growth factor, from there you can bring it in to this, it's vital for growth and development. It's an anabolic hormone, like it doesn't let in glucose out, it wants the glucose inside. So where is the glucose used for the rest of the things? You can remember it like that. That is not actually the mechanism, but something to make it remember, stick it in inside your head. Nutritional factors, deficiency in proteins, calories, micronutrients lead to stunted growth. So this point is very, you'll remember it very easily. Obesity resulting in overnutrition. So obesity is same point from social. Other factors, trauma and drugs. Androgenic hormones may accelerate growth, whereas trauma to epiphysis can retard it. So androgen tied to endocrine. Infestation tied to the, what is it, social factors. Cultural factors, taboo and feeding practices. Yeah, there could be a lot of like the family members might not allow the mother to take certain food, and the child is and because of that the child is not developing, not growing properly. Yeah, so all of those, like under each heading you can write something because it usually adds up. But loss of growth in children, this is something, the headings I think very important, because those are laws you can't change. The laws are there and you can't change. Continuous and orderly process, that is number one. So what happens if it is disorderly? It is a neoplasia. Unique pattern, each individual has distinct growth trajectory. So stem cells turn into something else, and these they have a specific pathway to go to, ectoderm, endoderm. Yeah, you remember all that, differentiation and all that. So using various signaling pathways and all that. So there is a specific unique pattern of growth of each individual tissue or cell. Cephalocaudal and proximodistal growth. So cephalocaudal, head to toe, proximodistal, ear to ear, shoulder to fingers. Variable pace growth, where rates vary. For instance, infancy and puberty. So the rate, the speed at which the growth happens, it is variable. Yeah. Neurohumoral regulation, growth spurts at puberty are regulated by hypothalamus. Yeah, this one is fine because I think that pathology, what is it, the anorexia nervosa, I think that is the one wherein you have a hypothalamic hypothalamus is affected. Yeah, amenorrhea happens, and the gonadal issues because of this one, not eating enough. So hypothalamus, how is that related here? No, the thing is not cause and effect per se, but the word hypothalamus could be attributed to gonadal, FSH, LH and all that, gonadotrophins. Yeah, anything else? Yeah, appetite, growth spurts at puberty are regulated by. Overall, hypothalamus does a lot for growth. We don't see it. We call growth hormone and all those guys. Yeah, tissue specific growth patterns. So there is general body growth, gonadal growth, lymphoidal growth, neural growth. So there is this body, and there are so general body that is number one. Other one is lymphoidal. Lymphoidal, that is another one. So lymphoidal, what comes to my mind is the thymus, where after a point in time it just disappears and goes somewhere. It doesn't stay there. Sorry, it doesn't go anywhere. And agenesis, I think it's called agenesis, and gonadal growth. Gonadal growth is reproductive growth happens during puberty, and neural growth, wherein after a specific point in time, you don't have to specifically measure. The brain has grown, the nervous system has developed, matured. So brain achieves 60% of its growth by the age of 2 and 90% by the age of 6. So developmental milestones. After that point, you don't measure it. Methods of growth monitoring. So methods of growth monitoring, there is so anthropometry specifically. What can you remember? There is weight, there is height, and there are a few circumferences. So circumferences, what are they? Head circumference, chest circumference, mid-arm circumference, and what is the other one? The thickness, fold. The reason I'm able to remember all this because I did it just 1 hour ago. That was not the case when I was doing it. I was like, what's happening? About an hour ago. No, I could remember some things, but right now I'm able to remember a lot more. Yeah, so bathroom dial, so weight measurement, bathroom dial, weighing scale, electronic weighing scale, infantometer. This actually should come in. Length and height shouldn't be there. It's not the case. Infantometer. Okay, I think it's obvious. Yeah, better to remote later on. Yeah, normal birth weight. So when talking about weight, this is pediatrics. We need to mention about normal in babies, 3 to 3.5 kilos. That is worldwide. But in case of India, it is 2.8 kilograms expected weight gain. So here there was this mnemonic that I found. So expected weight gain. So 30, 20, 15, 12, and the mnemonic ended up wrong. I think it was wrong. Think of 3 months gap with weight gain decreasing 30, 20, 15, 12. So 30, 20, there is 10 gram decrease. There is 5 gram decrease. Here there is 3 gram decrease. So 30, 20, 15, 12. So 3 for every 3 months, 10, 5, 3. So from 30 it becomes 20. From 20 it becomes how much? 15. From 15 it becomes 12. So that is 3, 6, 9, 12. So gram per day. This is even important in practicals because it's given the practical record also. Then there is birth weight. It doubles. So 2x 6 months, 3x 1 year, 4x 2 years, 4x foreign exchange. Yeah, so where is it? Yeah, 2x 6 months, 3x 1 year, 4x 2 years. Next comes length and height. So infantometer, yeah, this is used to measure height. So this is used for children less than 2 years. So if greater than 2 years, stadiometer is used. So infantometer, there is horizontally placed and you measure length, but stadiometer is vertical and you measure the height. and specifically relating to stadiometer, there is term called as Frankfurt plane, wherein the eyes look straight at the horizon, straight, and you don't do this or this, and you remove the chappals and you stand with your feet, like the back of the feet and the buttocks and back touching the wall should be straight, obviously, and then you measure the height, that is stadiometer. Normal range is 50, 75, 87.5. This is you need to remember 50, 75, 87.5. So some terms, like I think I remember this. So telling some things like initial part, there's a lot of numbers to be remembered, and also developmental milestones, a lot to remember there. So after that, it just resembles medicine, like most of these things down, they resemble medicine chapters. So initial few chapters, I guess it is going to take a lot of time, but later on it could be a breeze, hopefully. Then height doubles at 4 years, triples by 12 years. So 2x by 4 years, 3x by 12 years. So 4 and 12 very important in case of height. And then mid parental target height formula. So girls and boys. So there is father mother plus 13, that is for boys, minus 13, that is for girls, and entire thing divided by 2, probably. That's the thing. And then head circumference measured using a non-stretchable tape from occipital protuberance to supraorbital ridge. Occipital protuberance, that is here behind, and supraorbital ridge here. Normal ranges. So here I think there was another mnemonic. What was it? Nu 6 some 5, Nu 615. Yeah, Nu 615. On this side it was 935. Yeah, that was the case, right? Yeah, Nu 615 935. So it starts from 33. Yeah, 33 to 35. 33 to 35, 9. Add 9 to that, and then whatever number comes up, add 3. Add 3 to that, and then whatever number comes there, add 5 to that, and on this side it's 9 6 3 Nu 615, and there is this Dien's formula: length by 2 plus 9.5 plus or minus 2.5. Yeah, it's this Dien's formula, length by 2 plus 9.5 plus or minus 2.5. like, hopefully we'll remember it, otherwise we have to revise. Microcephaly, head circumference less than third centile or less than 3 standard deviations. So this is like on the left hand of the, on the left side, yes, left side of the 50th percentile, you keep going down, and what is the third centile? That is 3 standard deviations. Yes, it is 3 standard deviations. Macrocephaly greater than 95th percentile head circumference. So that is, I think, 2 standard deviations. So that is the difference. Macrocephaly is 2 standard deviations. So the thing is, if there are 2 guys, you want to classify them as either macrocephaly. Classifying it as macrocephaly is much more like distinct. So head is little bit bigger than this, meaning more than 2 standard deviations. Okay, you are macrocephalic, but over here head is small, but head is more small. Are you sure this is microcephalic? Then you measure. So if it is less than 3 standard deviations, meaning it's like much more smaller, only in that case it is microcephalic. But macrocephalic is like slightly bigger, okay, possibly is a macrocephalic guy. Yeah, that's how, because I got confused even today. Microcephalic, which one 3 standard deviation, which one 2 standard deviation. Chest circumference measured the level of nipples, used to assess nutritional status of the children. 27 minutes. Normal ratio, head circumference greater than chest circumference at birth, now equal at 9 to 12 months. So equal at almost so 9 to 12 months. Chest circumference greater than, yeah. So this is the same point. It's like 1 year is the mark, and below 1 year it is opposite of chest circumference is less than chest circumference is less than head circumference, meaning head circumference greater than chest circumference, but in lower section that is chest greater than. Normally my chest is bigger than my head, so and I am greater than 1 year. Mid-arm circumference measured in children aged 6 months to 5 years. So 6 months to 5 years, who are those guys? Those guys probably in like you measure mid-arm circumference. Yeah, there was this question in comment. So there are a few kids in kindergarten and you measure their Anganwadi, I think, yeah, in Anganwadi, and you measure their mid-arm circumference. So from that you know it is less than 5 years. You don't measure mid-arm in like first standard, second standard, first standard, I think, yeah, like after that is third, fourth standard, you don't measure it. Normal, like these are numbers 13.5, 12.5. If you remember that, you'll remember everything. So 13.5, greater than that is green in Shakir's tape. Less than 12.5 is severe malnutrition, which is red. Skin fold thickness measured using Harpenden caliper. This is the first time I read that word, Harpenden. It's crazy. Harpenden caliper. But calipers, yeah, sure. How can what's the other way of doing? But Harpenden is the word you need to remember. Assess subcutaneous fat stores. Assess subcutaneous fat stores. So fat is measured with skin fold thickness. So that's the end of this big answer. This is for 10 markers. Next question. Short stature in 6-year-old, etiology, evaluation, management. Okay. Overview. Short stature is a common pediatric problem, 3 to 5% of the population. So from here, this number, we can actually get the half the definition, 3 to 5%. So less than 3 centile, less than 5 centile. So these are the 2 points. So less than 3 centiles, when you measure height or length for age, that is 3 centile. But 5 centile, which is equivalent to less than 2 standard deviations. So 3 standard deviations comes to about less than 3rd centile. 2 standard deviations comes to less than 5 centile, or 5. So below the median age for age and sex. So both age and sex, but in this case it is just age. I got confused. Like how, though I am reading this repeatedly from many, how many times did I read this? I think this question never came up in my head. Like define exactly. So it's really important that you read the definition properly. Otherwise it will be like yeah something. But now that I look at this, it's like yeah, if you take age and sex, it is a different way of measuring it. But if you just take the age, it is different. Yeah, that's fine. Then height, velocity. So half the definition is that 3 and 5. The height velocity less than 25th centile for age, less than 25th centile. So how do you get the height velocity? It's in the growth chart, so you can see the slope. Early identification is very important to optimize the growth potential. Etiology, what are the causes? So there are physiological and pathological causes. Physiological, see, one is this thing, what is it, you can't do anything because parents have short stature. Other one, you see there is something is happening, but eventually the guy is normal. So that is the parents, the familial short stature. That is due to genetic predisposition. Birth weight and height are normal. Growth weight, growth curve parallels the expected centile. So the curve is normal. Bone age is normal, meaning I kept forgetting this word. I remembered it just now. It is ossification centers. You check the ossification centers on X-ray. So based on that, you tell what the age is. And DEXA scan, I am not particularly sure whether it's used here. I doubt in resource limited countries. It's I think it's only the X-ray. DEXA, I am not. Is it DEXA? No, it is the other one. DEXA is something else. This is in ortho. I forgot. So I'm comparing a 25. It's for 25-year-old. Older people comparing to a normal 25 or 21-year-old. Yeah, that is the other one. That's also used to compare the bone age. T test. Something similar to that. Some kind of test is done. No treatment is required in familial short stature, because what can you do? CRISPR is coming, maybe that will work, who knows. A constitutional growth delay. Child has normal birth weight, but growth slows down in infancy, leading to height below third centile. So this comes from the definition at below third centile. Growth slows down in infancy. So that time it is slow in infant region age span. Growth accelerates after 2-3 years and remains parallel to third centile. So it accelerates and remains parallel to third centile. Then what happens when the guys in when the pubertal age comes up, adolescent age comes up, it's like it's not happening, it's going into the future. When bone age is delayed compared to chronological age, growth eventually reaches normal adult height. So this is a relief, because it is happening normal, he is turning into a normal person. No specific therapy is needed. I will keep this pen down. I think it is blocking my face. Yeah, and this will block my face. Yeah, so in constitutional, this is something similar to our physiology, catch up growth. When the child has, so sorry if I am interchangeably using the terms, normal casual terms, but it's actually child, infant, neonate and all that, those are specific terms. But in this case, so that I understand it much easier as I teach it to myself right now, and as I am talking, you guys find it more interesting, easier to understand. I doubt who is the target audience is currently, like who is watching this. I doubt it won't be final years for sure who would be writing exams. Is there you can't be watching this, you should read on your own. This is I'll talk about this later. Now I'll come back to this, pathological causes of short stature. So pathological causes of short stature, you remember the first question wherein there was what was it, the growth, the factors affecting growth. Yeah, that could be brought down here. Nutritional causes, undernutrition, chronic malnutrition, not overnutrition, that is different. Yeah, chronic systemic illnesses, so renal, so all the systems are there, renal, cardiopulmonary, gastrointestinal and hepatic. Chronic kidney disease, nephrotic syndrome, congenital heart disease, bronchial asthma. So some disease which is more common. So you just remember this, all the topics from Singi, you can fill this up. And malnutrition, celiac disease, yeah, this one is not there in, this is not important topic in Singi. Chronic liver disease, it is important, and Wilson's disease and all that, yeah, but you just put it as chronic liver disease. Chronic infections, tuberculosis, recurrent infections, yeah, very important. These can cause short stature. Endocrine causes, so these were there, these are here also. Growth hormone, obviously IGF-1, insulin-like growth factor. Poor growth velocity. Hypothyroidism, less of calcium, hypothyroidism, that is hypoparathyroidism. Hypothyroidism, coarse skin, goiter, constipation, delayed bone age. So this has been repeated so many times. Hypothyroidism, it's fine, it's obvious. Cushing syndrome, central obesity, moon phases. Not particularly sure how can it cause short stature. I'm interested in searching this. Can it cause a short stature? Yes, Cushing syndrome can cause short stature and common as central obesity. Inhibition of GH and IGF-1. Primary closure of growth plates. Direct catabolic effects, it's catabolism mainly. Cushing's equals catabolism of proteins. So you have so that's what healing is reduced and all that. So healing is very very important. So even growth, so if the normal homeostasis is not maintained, how will you fund nutrition for growth? It's not happening. So that's why you have short stature in this. Pseudo hypoparathyroidism, because less of calcium, bone size, short metacarpals. precocious or delayed puberty, altered growth patterns. Yeah, this is that one, pushing what is that, delayed constitutional growth. Genetic or chromosomal. So Turner syndrome, there are these symptoms. Down syndrome, so it's a case specifically in pediatrics. Noonan syndrome, this is, it's similar to Turner syndrome in terms of symptoms, that is short stature, webbed neck. That's why it is placed here in short stature, but it happens in males. Skeletal dysplasias, achondroplasia, this is autosomal dominant, yeah, I think it is. Disproportionate dwarfism, short limbs. Osteogenesis imperfecta, this is a genetic one, I think collagen 1, collagen 1 something, yeah, it's 1 I think. Rickets due to vitamin D deficiency, yeah, those are fine. Skeletal, you can remember that. Psychosocial, short stature. Deprivation dwarfism, what? Deprivation dwarfism, then you are not giving enough of emotional support, and the child, and the size of the child doesn't grow, the child is still small. Emotional neglect, stress, maternal deprivation, functional hypopituitarism with low GH levels. So it's interesting how these emotional factors play a role in causing physical symptoms, like childhood and adolescence. These are very time at which lot of transitioning happens, lot of things are moving upside, everything is upside down, and then if you have some kind of emotional stress, you have hormonal imbalance. Growth improves when child is placed in nurturing environment. Yes. Evaluation of short stature. Symptomatic approach is needed to determine the cause. History. So this is history, this is this one, evaluation meaning our case. So birth history, so prematurity, IUGR, birth weight, let's call that. Family history, parental heights, remember that formula, that one, height of mom plus height of dad plus 13.5 or minus 13.5 divided by 2. But the, yeah, and nutritional history, diet quality and quantity. So calories need to write. Systemic symptoms, chronic diarrhea, malnutrition, polyuria, recurrent infections. So this is one of these factors affecting growth. Developmental milestones, yes, stresses development. Physical examination, accurate height measurement using stadiometer, infantometer for younger children. Body proportions, upper segment, lower segment. So upper segment, lower segment increased of hypothyroidism and rickets, and upper segment, lower segment ratio, meaning upper segment is lower than lesser segment in case of skeletal dysplasias. Skeletal dysplasias, if you can't recall, these are the ones: achondroplasia, osteogenesis imperfecta, rickets, and hypothyroidism and rickets comes up. Achondroplasia, that is the one, that is the main one here. Chondroplasia, upper segment is to lower segment decreased, increased in case of hypothyroidism and rickets. Dysmorphic faces, so this one, okay, fine, some syndromes. Hypothyroidism, Turner's. Sexually mature maturity rating, early or delayed puberty assessment. Neurological signs, delayed milestones, cognitive function is affected. Growth chart and mid parental height. So this is that same formula repeated again. Plot the growth chart. Plotting is also very important in our this one, in our practicals. They ask. Investigation, first line, complete hemogram with ESR. ESR, why? Hemogram is for anemia, ESR is for chronic inflammation. Bone age assessment, X-ray, left hand and wrist. Delayed X-ray, left hand and wrist. Specifically, I think there's a way, meaning some kind of indicators where they look at things. Left hand and wrist. Left hand, this is my left hand, this is my left wrist. Clear. This X-ray. Delayed bone age, constitutional growth delay. So bone age is delayed. You remember constitutional growth delay. under that delayed bone age, but familial it was normal bone age. Yeah, there you got to GH deficiency and hypothyroidism in delayed bone age. Better to search delayed bone age. Should I? GH deficiency, yes, GH is involved in, yeah, in bone this thing also. Hypothyroidism, yes, these two hormones. So hormonal impact, it's more of skeletal, on skeleton also. So GH, hypothyroidism, and advanced bone age, precocious puberty, Cushing syndrome. Advanced bone age, Cushing's, precocious puberty, Cushing's. Urine, precocious puberty, Cushing's. What does that even mean? Advanced bone age. I didn't understand this. This one fine, understandable. Advanced bone age meaning the age of the person is small, but because of early puberty he has developed a body. But Cushing's, I don't know how it is related to advanced bone. Child's career ahead of the maturation. Hypothyroidism, reactions increased heterogen testosterone. Yeah, this one is fine. Early epiphyseal closure, yeah, that's the word. Accelerated bone maturity at advanced bone age. Yeah, glucocorticoids are the one that advance the bone age. Is it looks like somewhat similar to. Does it mimic osteoporosis mechanism? I doubt, but sounds similar in that sense. Yes, it can mimic to catabolic effects on bone. So as the bone age increases, so when you become really old, you have less bone density. Is that the word? Because I remember mineralization and something else. Yeah, so yeah, these are somewhat similar. So advanced bone age. So in that case, Cushing's is there, and precocious puberty. Urine analysis, chronic kidney failure, disease markers, stool examination, malabsorption and parasites. Blood tests, urine creatinine, calcium. So writing all the, what is it? No, not everything. Like urea creatinine. So kidney function test, kidneys, calcium for these assessed kidneys. Glucose, what does this assessment mean? Glucose, I think for Cushing's, not for Cushing. Your blood, yeah, I think for Cushing's. And alkaline phosphatase, bone breakdown, ALP. And then second line, what are the investigation? T3, T4, TSH, T4, TSH, karyotyping, for Turner's GH stimulation, clonidine induced GH measurement. How does this work? Meaning clonidine alpha 1, pulsatile moment, clonidine alpha 2, low GH deficiency, low GH response. So clonidine causes GH to increase, but if low GH, that means it's deficient. Insulin induced. So there is insulin induced also, which we are not going into. We should be, because it's there. Normally hypoglycemia triggers GH and cortisol is counter regulatory mechanism as a response, counter regulatory response. Blunt GH response indicates GH deficiency. Okay, I didn't understand. Blunt GH response, less GH, because it's too late at the night. It's fine. A blunt GH response suggests GH deficiency. So insulin and clonidine act in a similar way. So insulin, clonidine is directly. Insulin is like intermediate is hypoglycemia. That causing insulin. That causing what is that? That is this one. It causing GH and cortisol. Yeah. Celiac is anti-endomysial. So this is your memorization. Celiac. MRI, pituitary abnormalities, genetic study of syndrome present. Management. So treatment, parental counseling, very important. nutritional optimization. Yeah, you want to optimize how fast you want the child to reach there as much as it can. Psychosocial support, emotional well-being, regular growth monitoring, specific measure management, undernutrition, calorie supplement, treat underlying deficiencies. Okay, fine, this makes sense. Hypothyroidism, give thyroxine. GH deficiency, GH therapy. Turner syndrome, what can you do for Turner? FSH, LH? No, there is GH therapy. That's interesting. Estrogen at puberty. Estrogen is for sexual related, GH is for growth related, because short stature is the problem in Turners. Celiac, gluten free diet, because skeletal dysplasia, orthopedic intervention, chronic disease, treating underlying conditions, psychosocial, short stature, improving family dynamics. Yeah, this one, emotional factors causing physical manifestations. So second topic is done, second section. Then failure to thrive. Doubt this is as important as the previous two, but since it is here, we need to cover. Failure to thrive refers to a condition in which infants and young children who fail to grow and gain weight appropriately due to calorie deficiency without an obvious medical cause. It is diagnosed when anthropometric criteria, these two are, either of these are fulfilled, either of these. Weight persistently below 3rd percentile, weight less than 80 percentile of expected weight for age, weight persistently below 3rd percentile for age, weight less than 80% of expected weight for age, less than 80%, persistently below 3rd percentile for age. So see, these are the small things. This is due to some reason this feels like maths. It's like all numbers look same. It's like plus minus everything. Weight percent below 3rd percentile. A child's weight consumed below 3rd percentile growth charge is a chronic undernutrition. Less than 80% for expected weight or standard growth. If actually less than 80% of the ideal weight is okay. A child's weight consistently remains below 3rd percentile. Isn't this much more worse than the second one? Isn't first one much more worse than second? Because see, 3rd percentile is like there. This is like 80% of expected. It should be fine, I guess. 80% of expected. Yes. And more concerning weight less than, but severity depends on the context. Growth failure, so just long term undernutrition. Okay. Severity should be in normal percentile range. Yeah, dropping from 50th to 10th percentile. But if percentile below they are lowest 3% are suggesting more severe malnutrition. Yeah, high percentile 50th suddenly drops below 80% of the expected weight. So 50th is the median, that is what 50th is the median, and below that, that means that is in the middle. Most of the people are there, and 80% of less than that, meaning 80% mark, 80% of the mark on the left side. In that case, yeah, it means that not percent and percentiles, different concepts. So that is why it gets confusing. So this means, so this is a graph, 80th percent of expected, meaning normal intuition says it should be here, meaning extreme right, somewhere 80th, I think 80th percentile, this is 3rd percent, but that is not the case. Actually this is in the middle, so most of the people are here, so it comes somewhere here. So these are almost on the negative side. Not that, that is something else altogether. Persistently below the, even now it is confusing, but it's fine, it's definition, we are supposed to know that due to some reason, meaning in this specific case failure to thrive. Persistently below third percentile for age, less than 80% of the expected weight. Like now that I've gone through ChatGPT and all that, now it can stick more easily. Causes of failure to thrive, FTT causes. So non-organic, organic, inorganic. GRD number 1. Malabsorption. So failure to thrive. So growth is affected or failure to gain weight. Malabsorption. So all the disorders wherein you can't grow. So and divide it into systems. GRD, malabsorption. This is under GI tract. Justifiable lactose intolerance, where malnutrition. Okay, chronic regurgitation of reducing food intake, fine. Neurological disorder, cerebral development, mental retardation. Why is this the case? Probably because secondary factors. After this, probably you will end up with failure to thrive because you are not eating enough. Yeah, it is that. Like how else is neurological? Renal condition, renal tuberculosis disease, chronic kidney disease. Probably because some hormones are affected there. Failure to thrive. Congenital heart disease. Metabolic, increased metabolic with poor intake. Okay, fine. This one is fine. Endocrine disorders, hypothyroidism, diabetes mellitus. Hypothyroidism. Okay. Wait. This actually needs little bit of cross checking of why that is the case. In all of this, metabolism of diet, this one is fine. Lead poisoning for diet. Genetic syndromes, Turners and Downs. 26 seconds. Turner and Downs genetic syndromes. Like why exactly? This one makes sense. Okay, fine. You have less of this thing. I just finish this section, then after the break. Congenital heart disease. Wait, let's see. Why failure to thrive? Wait, no, later. Aversion to food. Yes, it's a behavioral issue. Difficulty swallowing, possibly, yeah. Motor issues. Down syndrome, motor issues. Malabsorption. Congenital heart disease, increased metabolism, increased energy, hypoxia. Inflammation, yeah, hypothyroidism, metabolism, altered metabolism, electrolytes are gone in the urine, and nutrients are also gone, slowed metabolism, poor appetite. Yeah, hypothyroid, I thought it increases. No, that one increases, this one decreases. Diabetes mellitus, high glucose, lead poisoning leading to affects iron absorption. Failure to thrive in a nutshell. No, leave this. Next is should we finish? Should we go through this section? I feel I need to take a break because otherwise I'll be slower. So I think I'll take a 10-minute break and come back. That will be nice. Let's see, I'll turn this on. Yeah, 10-minute break. Close this. This one, let's see. Working fine. Yeah, this goes back. I'm out for now. I'm to rest. I'll drink some water and come back. Is there any way of turning the cam off? Video capture device off. Yes. Now you can't see me. So 10 minutes. I'll be coming back after 10 minutes. Till then, even you can take rest. I'll turn even the hello. I don't know if you can hear me, but mic aux, even this one should be off. Volume. I drink some water. I change it the next time. Make sure to understand how this thing works. Hello, welcome back. So we were here in the. I drank some water. Felt really good. Hydration is very important. Non-organic causes. So non-organic, not organic. These were the organic ones. Maybe it's better if I copy this and put it in this Google Doc so that it's easier to reference. It's very hard. Wait a second. I think I need to Sorry about that. Wait. Yeah, something came up, so I had to leave. Should I start this again? Yeah. I'll start playing this, and yes, non-organic causes. So these are, as the name suggests, not organic. So did we paste it here? Why did I do this? I need to copy it properly. Yes, failure to thrive entirely. You copy it like this and paste it here. Yeah, so this one is a good, gives a good broad summary rather than what I pasted here. So I'll see, in case I have time later on, I'll just replace this with the other one. Yeah, non-organic causes. Poor intake, inorganic, inadequate feeding practices, lack of parental knowledge, poverty, fine, understand, misperceptions, over dilution of formula, restrictive diets. So behavioral knowledge, that is what's missing. Lack of breastfeeding, improper feeding methods, maternal malnutrition, fine, affects breast quality and quantity, social and emotional deprivation, children in neglectful or abusive households, maternal psychological illnesses, depression or stress affecting caregiving. Fine. Yeah, so mainly the second part is behavioral, social plus behavioral. Yeah, social plus behavioral. So this one comes under behavioral. Malnutrition. No, this one comes. This is actually organic, but in a different sense. Mom is not eating properly. This is this one, psychological, social, psychological, social, behavioral. Behavioral, not enough food. Fine, that is psychological. Clinical features often present in poor weight gain, weight loss. Okay, a delayed development in cognitive impairment. So lack of nutrients. So development is impaired. Brain requires nutrients. That's gone. Expressionless faces. Let me check with the. Yeah, it is on. Yeah, I was thinking if the mic is off and I'm simply talking without the mic on. Expressionless faces, lack of interaction and emotional response, poor voluntary motor activity, delayed speech and vocalization, irritability or lethargy. Okay, so generally a child which is malnourished, I think that is what is being shown here. Yeah, that is the only thing that makes sense. Like delayed development, expression faces. Okay, yeah, the motor activity. Yeah, basically malnutrition, child with malnutrition. Diagnosis of failure to thrive, history, diet history, very important, type, frequency, quantity, parental and family history, genetic predisposition. What genetic predisposition? Okay, yeah, these genetic predisposition, yeah, makes sense. Immunodeficiencies, for example, and next, coming to developmental milestones, delayed or regression in skills, social history, family interactions, maternal health stresses, medical history, chronic medical illnesses. Yeah, so organic causes, any of that, social history, so all of that, meaning I spoke right, behavioral, social, maternal side, in case any problems. Physical examination, anthropometer, height, weight, BMI, on growth charts. Mid-arm circumference identifies malnutrition, upper segment lower segment ratio, increase in hypothyroidism, decreased. Yeah, so upper segment US-LS ratio, what was it? So yeah, so it's here only. I was trying to recall the previous from the previous answer. There were two, right? So the rickets was increased in hypothyroidism and rickets, decreased in skeletal dysplasias. Systemic examination, look for congenital, metabolic or chronic diseases. Lab diagnosis, essential test, CBC, urine analysis, renal rule out kidney disease, urinary tract infections. So basic examinations, I feel. Yeah, basic, these are all basics. like in case you get the etiology, the causes organic, inorganic, non-organic. This relies mainly on the organic causes, endocrine and metabolic screening, and even this one TFT, T3, T4, ALP for rickets, serum calcium, phosphorus, okay, burn, creatinine, chronic kidney disease, okay, fine, insulin, diabetes. Advanced tests, kidney Turner syndrome, sorry, not kidneys from that. This is karyotyping. Karyotyping is for Turner's and down. Serum immunoglobulins for immune deficiencies. GS stimulation test, which we remember we studied clonidine, insulin, which is used. Celiac serology. So mainly 3 sections under lab investigation: essential, endocrine, advanced. Management. Management meaning treatment. General principles address the underlying cause. So coming to the first part of failure to thrive, look at what it is. Improve nutrition intake, then you improve the behavioral, that is nutrition intake, then you also again look at behavioral. So first we look at organic, and 3 points for behavioral: improve nutritional status, parental counseling, psychosocial support. Dietary management, calorie intake 120 kilocalories per kg per day. Supplement vitamins and minerals, iron, zinc, vitamin D. Ensure adequate protein intake, milk, eggs, lean meats, legumes. Monitor feeding behavior, encourage structured meal times. Increase calorie intake, supplement vitamins and minerals. I think general principles, the same thing. Like this one, second point is put here: treatment of inorganic. So the first point, more of that here: hypothyroidism, thyroxine, celiac, gluten-free diet, GH therapy, chronic kidney disease, fluid and electrolyte management. Psychosocial, stimulate the child, encourage play and social interaction. Yeah, positive environment in general. Yeah, positive reinforcement here. Improve maternal mental health, support for depression or anxiety. Yeah, mother's physical health and mental health both affect the child. Yeah, this is interesting. Address poverty related. Yeah, this behavioral, in case mom is too depressed, child is not getting enough of breastfeeding, or breastfeeding techniques are not right. Hospitalization indicated if severe malnutrition, failure to respond to outpatient therapy. Yeah, fine. So if earlier ones are not working, so behavioral and organic we have seen, we go for hospitalization. Failure to respond to outpatient, suspected neglect or abuse, severe dehydration, metabolic disturbances. Long term follow up, regular growth monitoring 1 to 3 months. Developmental progress, speech and motor skills. So developmental milestones and growth monitoring. Growth charts, developmental milestones address emerging nutritional concerns. So what could possibly go wrong? Check that any other nutrients which could this thing, for example, look at folate and B12 together. Complications: growth retardation, stunted height and weight, developmental delay. Yeah, same thing. So growth monitoring, retardation, developmental progress, developmental delay, emerging nutritional, that is not the multidisciplinary. That's so meaning learning disability is covered here. Social workers, no, this is a psychiatrist, learning disabilities, even social workers, fine, psychologists. Increase susceptibility to infections, so that is weak immune response, so nutrition is affected. Psychosocial consequences, so eventually that is going to happen. So fine, no problem. We are done with that topic. Like anyways, doesn't matter how bad the patient situation is, we are here to learn. I don't know how that came up. It's like too abrupt, like at the end of an answer. I'm like, it's fine. doesn't matter how bad the situation or the patient is, we are here to learn. You don't know how it doesn't add up what I just said in this particular context. Coming to growth chart, this is a very important topic. Growth chart are essential tools to monitor physical growth, nutritional status, and children over time. These charts record weight, height, head circumference, BMI. 4 things: weight, height, head circumference, BMI, helping in early identification of growth disorders and malnutrition. Early identification, that's the key word. So Anganwadi people, mom brings the child and they keep measuring the height, weight, head circumference, BMI, and that is the road to health card, widely used in pediatric health tracking. A definition: so graphical representation of growth parameters such as weight, height, head circumference, BMI plotted over a period of time. So it is not just one single point in time, it is a period of time, allowing comparison with standard references. So it is not an isolated measurement over a period of time. There are multiples. You compare it with others. That's how you get the normal. You compare it with others. These charts help us a deviation in normal growth patterns and are crucial in detecting growth failure, malnutrition, obesity, or endocrine disorders. So what is causing these? So that's what screening for any of this. The first step is growth, road to health card. Importance: early detection of growth disorders. So failure to thrive, obesity, stunting. Nutritional help assess undernutrition, overnutrition, micronutrient assessment. So growth disorders. So that is disorder. Second one, nutritional assessment. You are not eating properly, or that's what, under eating, overeating. Monitoring development. So that is growth. Development, it's like ensures appropriate growth trends in relation to age and sex. Not specifically clear. Development means something else. Ensures proper growth trends in relation to age and sex. Public health planning used in growth in government plans and programs to track. So overall public policies to measure, like you give out all those free food and all that, right? So that comes in this. You can measure all of this and determine like how much you give and all that. So policy planning. Types of growth charts. World Health, WHO growth charts, World Health, WHO growth charts, CDC growth charts, Indian growth charts. WHO growth chart, WHO, I'll call it WHO because it's faster. It's from 2006, derived from longitudinal and cross-sectional data from multi-center reference study MGRS 1997 to 2003. So this is the study, which is like somewhat hard to remember. MGRS 1997 to 2006. So 97 to 97, 98, 99, 2001 to 6 years or 5 years. 6 years, yes. Sample includes healthy exclusively breastfed infants from Brazil, Ghana, India, Norway, Oman, and the USA. BGI NOU, BIG NOU, Big No, MGRS Big No, BIG NOU. Yeah. Represents optimal growth in children under ideal nutrition and healthcare. So first it's the study. Second one is which are the countries, Big No. Third one is optimal growth under ideal nutrition. That's the key. You look at normal breastfed infants, exclusively breastfed healthy infants, used globally to compare growth trends across different populations. Next one is CDC chart, NCHS 1977, data revised by CDC in 2000. So this is a different study, data set which is used to design the CDC growth chart. BMI for age charts for better assessment of obesity trend. So obesity is checked with BMI for age section part. Uses formula fed and breastfed infants, making it more representative of the US population. So CDC, it's from the US. So formula fed and breastfed infants, so mainly applicable in that particular geographical location. Indian growth charts, ICDS growth charts, IAP growth charts, Agarwal growth charts. So 3 names. Indian country specific charts tailored to Indian children are used in pediatric clinics, hospital, national health programs. Components: percentile curves, standard deviation curves, Z scores. Percentile curves, frequency of distribution of population. So if the child is on the 70th percentile, means 20. That's like basic Gaussian curve, where most of the population is in 50th percentile, and the people who have higher are placed on the right side, people who are lower are placed on the left side. And then if it is something like 51% greater, that means 51 people are under you, simple thing. Or 75% greater means 75 people are under you, 25 people are over you. Normal age between 3rd and 97th percentile, normal range. Yeah, so 3rd and 97th percentile. This is interesting. So you remember that particular discussion where failure to thrive, 80% of expected weight, equivalent to 3rd percentile, less than 3rd percentile of the weight. Somewhat similar. So between 3rd and 9th percentiles, like it is interesting. It's normal range in this particular case. Standard deviation curves, normal distribution. So one standard deviation covers 68.3, 2 standard deviation covers 95.4% of the population, 99.7% is covered in 3 standard deviations. So earlier we discussed some things. I think 3 standard deviation 99.7, no? 3 standard deviation percentage. Yes, it is 90. I thought it was 98 or something. It is just 0.3%. I thought it was 2%. So a little bit of earlier discussion. Which one was it? Something there, little bit of modification issue. But overall, I think in case the reasoning part, even if you throw it, like even if that part is, if you get the overall thing right, I think it is fine. Like I'm not a professor or something. Like for me, I need to write the exams to get this thing right. But anyways, there is a difference between percent and percentile, which is very important to remember. And that is what caused the confusion earlier. Yeah, 80% of expected for expected of the expected weight, that being equivalent to 3rd percentile. Standard deviation curves, yeah, that one is done. Z scores represent the deviation from the mean. This is little bit of extra trash. Observed mean by the mean standard deviation. So I'll clear this off later on. The child is 2 standard of mean. Basically, you ignore this. This is some code nonsense. Do look at this. Yes, about 2 standard deviation above the mean, meaning 2 Z scores above. So 2 plus 2Z equals overweight, minus 2 equals undernutrition. How to interpret it? Normal growth follows a steady percentile curve without any major deviation. So this is not allowed. That's not an ECG. No crossing of percentiles over time. So percentile is like, for example, 50th can't go down to 40th or something. Like if it crosses and goes, probably it is like constitutional growth delay. I think it's seen there. Failure to thrive. Child drops percentiles over time. Suggest malnutrition. In case you are watching this particular listening video or listening to this or something, in case you find any faults in the reasoning or anything of that sort, just write it in the comments, send it in the Instagram DMs. Just don't leave it there. It's very important. It's really helpful to know where, like this is what is shown. I'll just deviate for a while. This is regarding this. This is what is shown, the display, the information and all that. But some things might be wrong over here. and we don't want wrong things to be on the display, and it's the responsibility as of a medical student. If you are a knowledgeable medical student, if you are watching this, it's your responsibility to point out the wrong things, that this is wrong, you are supposed to change this from here. Otherwise, if something is wrong, for example, I am the display guy here, I am explaining certain things, not explaining, trying to learn and trying to teach. If I am doing something like that and some part is wrong or something, you are supposed to point it out. Otherwise, we can't get the right amount of correct information out, and people will learn and observe wrong things, meaning things that are not correct, and then that enters their brain. But if you have that particular comment there written down or something, it acts as a proper balancing force that maintains true knowledge. Yes, coming back, failure to thrive. Child drops percentiles over time, suggests malnutrition. So a sudden drop, it points towards failure to thrive. Suggests malnutrition, chronic illness, or growth hormone deficiency. Obesity. Child's BMI for age exceeds 95th percentile. BMI for age. So this was a part of CDC growth chart. Yes, it's so common, obesity in the US. Crazy. Stunting, chronic malnutrition, height for age less than third percentile indicates chronic undernutrition. Wasting, acute malnutrition, weight for height less than third percentile suggests severe acute malnutrition. Yeah, there are some terms. So for obesity, you check BMI for age and the number is 95th percentile. For stunting, it is height for age less than third percentile, height for age, and weight for height. That's for wasting, weight for height, meaning you are tall but your height is, you are eating very less, you are very thin, that means your weight for height is less, that means you are wasted. Stunting meaning your height only is less. Steps in using growth chart. Plot measurement correctly, compare reference percentile curves. So there are different percentiles, so that is one of the component, right? So you need to use that component, don't simply leave it there. Assess trends rather than single readings. So it is not the point in time, not the plot that matters. What matters is how it goes. It's a curve over time. Investigate abnormal patterns, crossing percentile, stagnation, rapid. Intervene early with dietary, medical, and hormonal treatments required. So we are done with this normal growth and its disorders. Next, coming to developmental milestones. So this is the thing is, this rarely comes up, but when it comes up, hopefully you'll remember it. Like this came up during our model exams. What I did was, they asked for fine motor, which is equivalent to this. I couldn't remember I could remember half of it somewhat, but then I couldn't remember till 1 year. So I did half of fine motor, rest of it I couldn't remember anything. So for that I wrote gross motor over there. So if you don't read this, it's really volatile, you can't remember this. I keep reading this for every posting, but I keep forgetting. Developmental milestone, but this time I won't. Developmental milestone, age specific skills and ability acquired by the child as they grow. These milestones covered in 4 major domains: gross motor, fine motor, language, social. So what the meanings of each of these? It's given over there. Hand-eye coordination, dexterity, includes speech, communication, understanding. Social involves interactions, emotional regulation, self-help skills. So up to 12 months, 1 to 3 years, 4 to 5 years. So 3 years I remember one. What was that? Gross motor, tricycle. Yeah, this one is very easy to remember. Tricycle. And there was another one. Which one was it? Yeah, something. Now it is how to remember all of this. Birth. So there is a better way to remember. I always use this. That one is from Arun Babu, but a record has better. I'm promoting my college record. Yeah, this one I studied this properly. So head control is for 3 months. At 3 months, head control is 3 months, rollover is 5 months. Probably I need to convert this and replace this with this, because this one I've studied it properly, but in case I don't know whether you guys have started going through this, but I feel this one I need to add this there, because this one is much easier to remember, because I remember it much more easily because I've studied it earlier. This one I didn't study it earlier, so I don't know if I should skip it or not. Anyways, what I'll do is, I'll take a photo of this and put it in the Google Docs, and eventually I'll remove this from the Notion page and add a new one from our college record. That would be nice. Like, anyways, right now most of my college friends are using this website, so it would be helpful, but eventually we'll see how it goes. So 4 months, 4 months is not here. It is 3, 5, 6, 7, 8, 9 months, 10 months, 11 months, 12, 15, 16, 21, 24, 30, 36, 48, 60. Yeah, head control at 3 months. Head control at 3 months. Yeah, this is, look at this. What is this? By the time you read this, you forget what month it is. That's why you need to read this. Head control is 3 months. So head control, you look side by side. Head control, so left, straight, right. So 3 months. Rollover is 5 months. Rollover, like rollover, for 5 months. So rollover is 5 months. How to remember this? How rollover is 5 months? This is a pen. The pen is rolling over. There are 5 pens. I don't have 5 pens, but those 5 pens are rolling over. So that's why rolling over is. Sit with support. This I had a very easy way to remember. I'll show it. If you can see it. How do I show it? Actually, this is from our pediatrics class. Sir took a extra session, small session. Like, it was a small group discussion kind of a thing for practicals. This is from that. Yeah. So 6. So 6 is, if you can see, I don't know if you can see, here you can see 6, and the 6 is the child and is sitting with support. So 6 months means sitting with support. 5 means rolling over, because there are 5 pens which we are rolling over. I don't know if there is a see, I think it is better to remember it everything. So in case you don't want to listen to this and you have a better way to remember all of this, you can just skip this developmental milestone section. But if you would like to see this, probably it is really interesting and entertaining, like how I am trying to remember all of this, then you can keep watching. Otherwise you can just skip this section, because it's just trying to memorize some weird milestones which are really, it's very hard to. Sit without support is 7. So the 6th guy, so this is with support. What is without support mean? Without support mean opposite of with support. So opposite means like this. This is, so you remove the 6 from here. So 6 is not there anymore, because opposite of being is not being. So 6 is gone. And this is 7. 7 is without support. That's how we remember. Pivoting is for 9 months. So the 6 that was here, or the 9 that was here, which we cancelled, he pivoted somewhere else. Is that 9 or 6? No, it is 9. Is it 9 or 6? It is 9. Yeah, it is 9. I think I got confused a little. So the thing it pivots somewhere else. I don't know what that means. The pivoting is like this, like you use one. So 9 has one foot, and it pivots. So pivot starts from P. I doubt you can see this. You won't be able to see what I'm doing. So you can try to close your eyes and imagine. So imagine there is a 9 who is standing. 9 meaning the number 9, and he turns to the other side, meaning pivots. It will look like a P. So P starts from pivots, and 9 is the pivoting stage. So 9 is covered, and then stand with support. So 9, how many legs does 9 have? 9 has 1 leg. 9 has 1 leg, because if 9 had 2 legs, it would look like an R. Can you imagine? It would be an R. It's not an R, it's a 9. So what does a 9 need? It needs support when it's standing. Yes. Next, crawls. Crawling is at 10. Crawling and standing without support. Don't know how exactly to remember this. Crawling and standing without support. Standing without support. I don't know crawling and standing without support, but walk with support I can. I have a very nice way to remember that. So imagine a human who is holding crutches, and the crutches look like 11. So that person is standing with support. So he's standing with support. So crutches are the 11. So standing with support, you need to imagine it. Close your eyes and you need to imagine this. A person is standing with crutches. There are crutches on either sides, and those resemble 11. Creeps. And then what happens? Then a bad person comes up, a villain, and he throws those crutches away, and the person falls. And because of that, the person who was standing with crutches, now he has to creep. Do you see how the 11 is related to both of these? So it is 11. It's not absence of 11 being something else. It is 11 only, because crutches are still there. Crutches are fallen down. Next, walk without support. That is 12. So at 1 year you walk without support. At 1 year, like 1 year, it's a milestone, important milestone. So at that point, walk. See, this is what, and this particular thing is different. Here it is. Both are. I'll put this thing over there, the record thing. That's better. Walk sideways. Walk sideways at 15 months. 15 months. So 15. At the age of 15, so I'm not thinking right. You walk sideways. You don't walk straight. It's like you're walking sideways at 15 years, but here it is months. Running at 16. You walk sideways. Then what do? Then you realize that you are to start running, because NEET is in 2 months. Sorry, in 2 years. You are writing NEET at the age of 18. So right now your age is 16. To start running for 2 years, only then you will be able to crack NEET. Yes. Walking backwards. So where do you reach? So 16. So now I'm taking months as years. So 16 months. So 16 months was running, but actually I made it 16 years so that you can compare it with NEET. And 16 years, 17 years, 18 years. At 18 years you enter the medical college. 18th your first year, 19th your second year, 20th your third year, hopefully. 18, 19, so third year, yeah. In third year you are in 21. So what happens at 21? What happens in third year? You have ENT, you have forensic, you have Aftal. You don't study a lot. Then what do? In second year you studied so much, but in third year you don't study a lot. What happens? You start walking backwards, you don't walk forwards. So that's what is happening. At 21 months you start walking backwards. Then what happens? Third year done. So now we are 22 at fourth year. Now we are in final year. That is 23. Sorry, 21, at 21 you are in third year. At 22nd you are in final year. 23rd you are in internship. And 24, what happens at 24? Your internship is done and you are writing NEET PG. You get a good seat. At 24 you are in PG. And what does that mean? You are walking up. You are walking upstairs. You are walking upwards in life. Till now you are constant. Now you are walking upwards with your PG. So that is walking upstairs. I will put this somewhere so that you can understand what I am trying to say. Right now you might not understand watching this, but in a different tab you will be able to put whatever I am trying to say, and it will make much more sense rather than what reading this. It's very difficult to remember that, and it's a lot of milestones actually, and we have not yet covered the gross motor. Yes, next coming to go upstairs with alternate feet. Then at 24 you started with your PG, and after 6 years of doing PG, what happens? You are very much experienced. Now you can use alternate feet to walk upstairs. Earlier what you did, you were inexperienced, so you used 2 feet, like you could go upstairs but not properly. Now you can use alternate feet at the age of 30 because you are a lot more experienced. Next, rides tricycle. Yeah, that is the age of, that is the 36. So 36 meaning 3 years. So that is what at 3 years tricycling. That is the only thing which I can remember, which most of the people can remember easily. Hops on one foot, that is at the age of 4 years. So hops on one foot, that is easy actually. Sir also spoke about it. It's like 4 is this. So it's like a person standing with his legs, one of his legs is leaning on the wall, one of his legs are crossed and the sole is facing the wall. So his legs look like 4. I don't know if I think I'll upload a diagram also, like some places diagrams would be nice. And skips, that is 5 years. I think how do you remember 5? Skips at the age of 5. Skips at the age of 5. I don't know how to remember this. Skips at the age of 5. Next, fine motor. Follows objects 90 degree at first month. Follows object 90 degree like this, like here to here. I think it is like this. It follows object. No, just eyes. Like this, like here to here. Can follow object. Next is follow object 180 degrees. That is at 3 months. So mainly it's about fine motor start from ocular muscles. So 90 degrees is first one, 180 degrees is the second one. Third, reach for object is 4. Reach for object. Can reach for object. So that is the one. So that is at the 4th month. Ulnar grasp. So I tried to remember it with this ulnar grasp, with this, like on the ulnar side we make a 6, like though it is very inconvenient, like something I don't know how else. What's the other way of doing it? It's like you can do this. You can do this on the table, like this, thumbs up. Ulnar side has 6 on it. I don't know. Radial grasp. Like when you do this, yeah. Now it makes much more sense now. And just thought about this just now. When you do this, right, on the ulnar side it is 6. On the radial side it looks like 7. Like if you look at it properly, if you try to understand it, how it looks like. On the radial side it looks like 7. On the ulnar side it looks like, so ulnar grasp, radial grasp, 6 and 7. Transverse object back to 6. So transferring. I don't want to read this meaning. Transferring object. Pincer grasp is 9. So similar to pivoting, which is starts from P and pivoting 9. It's at 9th month. So similarly, pincer grasp, it starts from P and it's at 9th month. Releasing objects. So you remember the story where the guy was standing with the crutches and you called it 11. and you release the crutches because of the villain, and now it is 11 again. So releasing objects, turns the pages of the book. So this you can see, it is slightly complicated right now when I am talking about 12 months. 12 months because now I am connecting gross motor and fine motor together. So gross motor, maybe a better thing would be using some kind of an iPad drawing screen and just show it. That would have been nice, but it's fine. I'll see if maybe something like that is possible in the future. But anyways, you can listen to me now, or else you can skip this entire thing and go to the next section, because just this is just a way, since exams are coming up. I think today is 8th, no, now it's 9th. It's 9th right now. So after, I think on 17th we have exams, or on 7th we have exam. It starts from 7th. So I thought, anyways, we need to keep the channel active, and I need to study. Why not study on the channel? So that's what I'm doing right now. And since if I do it by myself, I might skip certain things, but when I'm doing it and somebody is trying to learn something, I might not miss things. So I'm trying my best to study and not miss anything, and it serves two purposes. One is content for the channel, other one, what is this, me finishing the topics. Anyways, coming back, so turning pages of the book, it happens at 12 months or 1 year, and then walking without support also happens at 12 months or 1 year. Do you see the correlation? The moment you start reading, you can walk without support. Yes, that's important. Next, build a tower of 2 cubes, 2 cubes at 15. Build a tower of 2 cubes at 15. So you start building stuff at the, no, 2 cubes 15, and multiple cubes actually. Then 2 cubes at 15, no, another cubes comes at 22. That is 6 cubes. At 22 you are developing with 6 cubes. Yes, like I want to use the child labor reference here. Like for example, it's like you are a double story building, you are a child laborer at the age, that is too much, right? It's an educational channel, we can't include that here. So anyways, you remember 15 months is 2 cubes, 22 months is 6 cubes. Drinks from a cup is 15. So you are walking sideways. I told you, don't walk straight. So as you walk sideways, what will you do? You drink alcohol. So that is one. Scribbling is 13. This one is something very nice. I told this to my friend. He found it very interesting and he liked it too. 13 months and scribbling. Do you see the connection? If you add the word Friday the 13th, what it is? What is it? It's a horror movie. What happens in horror movies? This guy, what is it? The ghost. If the ghost enters into a person, what does the person do? He scribbles. So Friday the 13th indicates scribbling. Yes. Next, coming to build a tower of 6 cubes, that is 22. So directly we jumped from 13 to 22, and that was for cubes. Before that it was alcohol, not alcohol, it was the drinking from a cup. Next, coming to vertical and horizontal lines, that is at the age of 2 years. So tic-tac-toe. Vertical 2 lines, horizontal 2 lines. 2 at the age of 2 years. This is a lot of overloading of information, not a single storyline. So it's very hard to remember, but for me it is something like I've already repeated the story inside my head so many times. But if I don't, even if I have the story in my head, if I don't revise this, I'll forget about it. That's how volatile this is. And the only thing that I would be remembering is the tricycle and the 3 years. And that's funny. Vertical, horizontal lines done. Copying circles. Copying a circle at 3 years. At 3 years. So this is also fine actually. So So tricycle, I told you, right? Tricycle has wheels. So wheels, what is the shape of the wheels? 0. So 0 is 0, copying 0 or copying a circle. Next, coming to 4. 4 is for square. So you can draw a square at the age of 4. Next, copying a triangle or an X and an X. So copying a square and a plus, that is 1 at 4. And another one is at the age of 5 years, triangle and an X, triangle and X. So that is at the age of 5 years. So parents give their children a PlayStation. What is that? PS5. PS5, PS4 at the age of 5 years, and that affects the developmental milestones. Okay, how is that related? So that is, I'll show you how it is related. So you know the PS5 controller, it has a few buttons on one side, like one is that delta, the triangle thing, and one is that X. Even that, those are buttons on a PlayStation controller. So remember, at the age of 5 years, that is when the child is just in first standard, you give the child a PS5, and there comes an X and a triangle. There would be better ways to remember all of this, but this is the way I remembered it earlier, and that's what I'm sharing. Next, coming to rhomboid. Rhomboid, it's 6 years. I never tried to remember it. 9 years is copies a cylinder. Cylinder at the age of 9 years. I think we can exclude it actually. It won't show up. Like I can't say it, but 9 months, 9 years, cylinder. Coming to language and communication. Turns the head to sound 1 month. So 90-degree eyes, that was around 1 month. 3 months was 180-degree ear to ear. Here it is, turns head to sound. So head control is achieved which month? Head control is 3 months, but turns the head to sound. So just turning head, but complete turning at 3 months. Cooing is 3 months. Cooing is 3 months. So this one, it's mainly pictorial what I'm trying to say. So cooing, so 3. So here you can see an image. Just look at this image and then close your eyes and imagine the image. So in this, the child is cooing. Can you see the child cooing? The tongue is out, and this thing looks like a 3. It's hard to remember all of this. Like I keep repeating the same thing. It's hard to remember, but there is no other way of remembering this. Babbling. So babbling is easy actually. Babbling is babbling starts with B, and 6 starts with B. So 6 months babbling. And bisyllable. Bisyllable is also fine, because that is the very next thing after babbling. So what you do is you flip the 6 over, it looks like a 9. So that is bisyllable. Speaks 2 words with meaning. That is at 1 year. So at the age of 1 year, what do? You walk without support. No, you stand without support. Wait. You walk without support at the age of 1 year. You start turning pages, flipping pages at the age of 1 year. What else you do? You speak with what is that? Two words. Two words with meaning. You speak 2 words with meaning at the age of 1 year. You are able to see by turning the pages of books. You can do so many things. You can start walking without support. You can speak 2 words with meaning. That's what. Till now he was not able to speak properly. Now he can speak. Next 18. 10 words with meaning. At the age of 18 months, 10 words with meaning. So that's why at the age of 18 years you are called an adult, because you can speak 10 words with meaning. This is completely nonsense what I just said, but you can correlate some things, like you can try to remember some things. Next, coming to 24, simple sentence. 24, you are able to speak. So what happened? What else happened at the age of 24? Meaning I am converting months into years so that it's easier to remember. What else happened at 24? Do you remember? Do you recall? You started walking upstairs because you cracked a neat PG. So similarly, here you are able to speak a proper sentence. Now you are heard in the medical fraternity, but medical students are not, meaning clinically we are not so experienced, that's why. But then when you speak, you are heard. And now it's a break. Should I take a break? I'll drink some water and continue. But I'll turn off the mic. Coming back. We took a break of 1 minute because I want to finish the developmental milestones. I don't like that section. So let's continue. We are in the language and communication, and yes, and this is something, now that I think about it, I should have just placed this one. What is it? No, you can come to this website, and I would probably update this entire section with the record, with my record, this thing, and you will be able to correlate more with what I am saying. So by the time the video is out, even this thing is updated. So that is nice. Yeah, it is nice. Yes, coming back. What was it? Yeah, knows full name. Simple sentence. You are able to speak simple sentence at the age of 24. Sorry, at the age of 24 months. Knows full name by 30. So I told you, like, alternate feet, walking with alternate feet upstairs at 30 months, which is equivalent to like coming up in life with lot of experience in the field of medicine and surgery. Yeah. So similarly, you have identified yourself at the age of 30 months. Like, you know your name, like you know yourself after so much of experience of talking simple sentences. Yes, coming to 36 months, age and sex. Knows age and sex at the age of 3 years. So at the age of 3 years, what else happens? Tricycle, copying 0, and this one. He knows age and sex at the age of this thing, 36, that is 3 years. Complete sentences of 3 to 4 words, that's the age of 3 years. Names one or more colors, that's the age of 3 years. So colorful tricycle. Colorful tricycle, speaking sentences of 3 to 4 words at the age of 4 years. So what else was there at the age of 4? The guy leaning on the wall was there. Square was there in fine motor. Square and what else? Square and a plus. And now we have in language and communication, tells an exaggerated story. Exaggerated story. You do that when you are 4 years old. That's interesting. Meaning, I am trying to imagine a young guy, young boy or a girl trying to exaggerate something. It's very hard to remember. Imagine that. Sentences with 4 to 5. So 3 to 4 was at 3 years, 4 to 5 at 4 years. So 3 and 4, maybe you can just like make it 3 in 3 years, 3 words, 4 words, 4 years, 4 words. Repeat sentences of 10 words. That's at age of 5 years. What has happened at 5 years? PlayStation. Yes. Triangle and an X. And skips. Yeah, what happens if you give your child of 1 year PlayStation console? He starts skipping schools. Yeah, that's how you remember the gross motor. Skips 5. At the age of 5 years, skipping happens. Yeah, skipping. Counting counts coins correctly. So when you play the when you play in the with the PlayStation, what happens? When you're a 5-year-old, what kind of games do you play? Simple games, small games. So in that you count, you get the coins. So in case Mario, right, Super Mario, in that you have coin system. So as you get more coins, what do? Count the coins on the game. This is turning more from a scientific discussion into a more creative discussion, which is really interesting. Personal and social. Social smile at the age of 2 months. Recognizes mother at the age of 3 months. So social smile. So smiling. So smiling requires 2 points. Edge of this and to the edge of this. The 2 lips. They start and end at 1 point. So these 2 points are required. So 2 points. So meaning 2 months. Like it's. I don't know whether I will remember it. I thought of it just now. Just because I have to find a way of remembering something, remembering these things, come up with some things which sometimes don't make sense. Recognizes mother at the age of 3 months. Recognizes mother at the age of 3 months. Okay. So yeah, this one is good actually. Mother starts with M. Mother starts with M, right? So if you rotate the M, it looks like a 3. Think about it. Next one, stares at one hand. 4 months. Stares at one hand at 4 months. So 4 months. So why would the child stare at its own hand? Because it's holding its hands like this, because it's 4 months. It's holding its hands like this and it's looking at it like this. That's why it's looking at it. Does it make sense what I'm trying to say? Meaning it is somewhat totally out of context what we are trying to remember. Like staring at, why would someone stare at their own hand? Like why would I stare at this right now? Only if I want to remember the developmental milestones. And here it is suggesting that at the age of 4 months, which is this, child being me, is staring at my own hand. Can you make sense out of it now? Yes, you can. Next one, smiles at mirror image. So that is at the age of 6 months. So 6. So 6 and is it a good way to smiles at the mirror image? 6. I don't know. I know a way to remember this, but I don't know if it would be appropriate to put it on YouTube. Like, that's why I won't talk about it, but find your own way of. Smiles at mirror image at the age of 6 months. Next, stranger anxiety, 7 to 8 months. Stranger anxiety. I can't think of anything right now. Waves bye bye. Waves bye bye. That is at the age of 9 months. So bye bye again, when you flip the B over, it becomes a 9. Next, mimics action. So that is at 1 year. So at 1 year, what happens? What and all happened previously? Like we are revised them and done, but now it is mimicking action. So so what pages did the child? So child had a book, right? It was flipping the pages. What was the child reading, which made the child walk without support? The child was able to speak words, 2 words with meaning. What was the book all about? It was biography of great men and women, and the child started to mimic the actions of the great men and women of the modern world. That's how you remember what happens at the age of 1 year. Next one, 18 months. Pretend to play with a doll. Pretend to play with a doll. That is at the age of 18 months. I don't want to put it on YouTube. Next, removes garment at the age of 20 months. So how do you remember this? 20. See, personal and social, 18 and 20, these two, I think you will have to find a way to remember this. Next, nighttime control of bowel and bladder. That is 3 years. 3 years nighttime control of bowel and bladder. So the child was what? It was tricycle 3 at the age of 3, circle at the age of 3. Here it is some what else? 3 words with at the age of 3. What else? No, sage and sex at the age of 3. What else? Can nighttime control of bowel and bladder. That also at the age of 3. Is there any specific way to remember this? Nighttime control. Let me start the timer. Oh no, I doubt we need the timer now. Anyways, we don't follow it properly. I'll follow it. The moment I finish developmental, this personal and social, I'll take a break. Next, nighttime control of bowel and bladder. So before this, it was not able to. Before the age of 3 years, it was not able to. So any specific way to remember it? I can't think of anything right now. Unbuttoning clothes and putting shoes on. Yeah, so when you play on a tricycle, do you do with your shoes on or off? Do it with your shoes on. So what does the child need to learn? Put the shoes on. Next, 4 years, plays with many children. So tells an exaggerated story. Hopping. What else? There was something else. Copying square and plus. And playing with many children, and goes to toilet alone. Plays with many children, goes to toilet alone. Goes to toilet alone, plays with many children. So that is, both go hand in hand. You can't play with children and not go to toilet alone. The children make fun, your friends will make fun of you if you are not able to. So that is at the age of 4. At the age of 3, it was personal development. What was it? It was unbuttoning shirt, putting shoes on. Yes. Next, dresses and undresses. That is at the age of 5 years. Domestic role playing. That's the age of 5 years. So something last one, role playing. It has playing in it. So playing video games with the related to counting coins and PlayStation buttons and all that. In case you want to remember, you can. Otherwise, you can find your own way. But right now, we are taking a break of 10 minutes, and then hopefully, I will come back. Hopefully, I'll start it now. So the break has started. Then we will be going over. Yeah, this entire thing is done. We don't have to Hey, this was the same thing. Copy circle, copy square. Okay, I didn't read this part. This one is fine. 2 words, 3 words. Recite sung small stories. Here it was exaggerated stories. Age of 5 it was what was it? Counting coins. Stranger anxiety 6, 7 to 8 months. And it's fine. 9, and by B you flip it over, it becomes 9. Imitates action. It mimics reading books and all that. You can find different ways of remembering this. There is no specific. Yeah, I think probably we can finish this developmental thing off. Group play, share choice. Son is that controlling bladder bowel. Like, I know I'm thorough with the milestones. Like, that's the best part about doing this with the study with me or kind of thing, or teaching to a friend. It's called Feynman technique. I think you know about it. Almost everyone knows about it. Wherein you teach what you know, or what you think you know, and then you find gaps in your knowledge and you try to fill it up. Clinical importance. Delays in any domain. There's something called a global developmental delay, which is less than 80th like developmental age by chronological age. If into 100, that is less than 80% in 2 or more domains, that is the global developmental delay. Yeah, that is the one. Then in developmental disorders we have CP. The break is still on and we are doing this. Autism spectrum disorder, impaired social and language development. Why am I saying we? It is not we, it is me that is there right now, but it will be we in the future. So it is up. Is it fine if I say we? I think it is fine because it comes more naturally. ASD, not atrial septal defect. Autism spectrum disorder, impaired social language development, fine. Global developmental delay. Yeah, this is the one. Delay in 2 or more domains. Red flags. Yeah, I think if you can manage to write this, this and all is all extra. Like, you can just add more things, meaning by this age, if the earlier things are not there, it's a red flag. Like, who will try to? Yeah, it's the same thing. No 3 words and no 2 word sentences. No walking. The crutches thing and all. Fine. This thing is done. I'm not talking about development delays again. Over. That's over in this channel. If just in case somebody else plans to take some kind of lecture or something on this YouTube channel, they can take up. But personally, I'll never ever talk about developmental milestones again. That's it. Now I'll turn the mic off. So let's continue. We are still in the development chapter, but this is a new question. Principles of development. So progressive maturation of function. So functional maturity. So everywhere the same thing comes up. Maturation of function reflected by sequential attainment of various milestones in physical, cognitive, social, emotional. It depends on brain maturation, myelination, environmental stimulation. So what is actually required? Brain maturation, myelination, and environmental stimulation. Development follows predictable patterns but can vary in time and manner among individuals. Understanding the principles of development helps in early identification. Principles of development, yes, that is the question all about. Developmental delays and guiding interventions. First one, development is a continuous process. Second one, sequence of milestones attained is universal. It's the same for everyone. Variability in time and manner of attainment. So it talks about variability. Development follows a cephalocaudal. Yes, this was one of the thing of laws of growth. Proceeds in the proximo-distal. This was one of the laws of growth. Primitive reflexes must disappear for voluntary movements to emerge. Okay, this is interesting. I never knew about this. Meaning, I read about it, but reboot. Development transitions from mass activity to specific activity. Yeah, going in detail. First one, it's a continuous process. Starts in the uterus, continues throughout the life. It happens in a predictable manner, but at varying speeds in different individuals. Skills built progressively with simple functions forming the foundation for complex skills. Yeah, so they have given one example here. Babbling turning into single words that in turn turns into sentences. So children develop in the same sequence worldwide, irrespective of culture or race. That's why we have universal developmental milestones. While timing may vary, so this is the key here. Timing, the time at which you get it, depends on lot of factors, including the genetics. The order is the same. All babies stand before they walk, and they reach for objects before they transfer them. Can you recall at what age this happens? Reach 4 objects, reach for, that's 4 months before they transfer them. So what, transferring, what did you transfer? What did the child transfer there? 11, that was 11 months. Yes, variability in time and manner of attainment. Each child develops at their own pace. Some milestones may be achieved earlier or later due to genetic or environmental factors. The child may start walking in 9 months, the another at 14 months, but both still within normal range. So as long as the range is fine, it is okay. So cephalocaudal, that is head to feet. Head control developed before trunk control before leg movement. Yeah, so top to bottom. Shoulder movements before hand movements, hand controls before fine finger movements. Primitive reflexes must disappear for voluntary movements to emerge. Primitive reflexes, like there are quite a few, like one of them they have given here, palmar grasp reflex. It must disappear before voluntary grasping of object occurs. The brain matures, reflexes disappear with the more of purposeful movements. Development transitions from mass activity to specific activity. Newborns exhibit random uncoordinated movements. Over time, it becomes specific and goal oriented. So it waves hand, but at the age of 6 months, it can reach out and grasp. Actually 4, a grasp. Yeah, you can remember the grasp, right? The thumbs up. 6 for ulnar, 7 for radial grasp. Yeah, again, development is a continuous process. Sequence of events sequence of attainment of this thing is universal. variability in time and manner of attainment, cephalocaudal, proximodistal, primitive reflexes before actual conscious voluntary movement, transition from mass activity to specific activity. Yes. The next one, breath holding spells. So, this one and next one very short, next three very small topics. So, breath holding episodic crying attacks in children that leads to apnea, that is transient cessation of breathing, loss of consciousness and changes in postural tone. These are reflexive, involuntary and self-limiting. Reflexive, involuntary, self-limiting. Three important, meaning tend to forget. They occur in response to frustration, anger, pain. 6 months to 5 years. Types of breath holding spells. There are different 4 main. One simple, cyanotic, pallid breath holding spell, complicated breath holding spell. First one, simple. Child holds breath after crying but does not develop cyanosis or pallor. So, there is no cyanosis or pallor here. It is brief and self-limiting. Second one, cyanotic. So, simple, cyanotic. In simple is not cyanotic. That is what they have said it here. Said it there. Cyanotic breath holding spell triggered by anger, frustration or pain. Child cries intensely. Start the timer. Yes, intensely, then stops breathing, leading to cyanosis, may lead to brief loss of consciousness. Pallid breath holding spell triggered by sudden. Pallid one is sudden pain or minor trauma. So, this one is emotional. Second one. Third one is sudden pain or trauma or fear. Child becomes pale, loses consciousness and may have limp muscle tone caused by excessive vagal response leading to bradycardia. So, here there is a physical stimuli or fear. Fear is the extreme emotional stimulus, that is what you can call it. Child becomes pale, loses consciousness and may have limp muscle tone. So, pallor. Excessive vagal response to leading to bradycardia. Complicated breath holding spell, severe form where the child loses consciousness and has brief seizure like activity due to prolonged cerebral hypoxia, lack of oxygen. Complicated, severe. The child loses consciousness and has brief seizure like activity. So, that is why it is complicated. Whenever you get the brain involved, probably you call it complicated. Due to prolonged hypoxia, EEG is normal. So, clinical presentation precipitated by stimulus like anger, pain, that forms one of the classification points. Forms one of the classes. Begins with crying followed by cessation of breathing. Child may turn blue or pale depending upon what class it is. May lose consciousness and become limp or stiff for few seconds. Seizure like activity may be seen in severe cases due to cerebral anoxia. So, seizures, excitatory, neural impulses due to cerebral anoxia. Post-ictal phase or incontinence. Drink some water. EEG remains normal. 6 to 18 months, peaks at 12 years, resolved by 5 years. So, 6 months to 5 years. Have we? Yeah, 6 months to 5 years. I think that should be enough for that. So, it could be differential diagnosis, could be seizures, cyanotic spells, cardiac arrhythmias, so loss of consciousness without crying, but it requires ECG, brainstem and malformation. So, management, parental counseling, reassurance that spells are benign and self-resolving. Patient should avoid reinforcing crying behavior. So, make sure the behavioral changes, teach parents not to panic during episodes. Identifying and avoiding trigger factors. Overprotection and excessive pampering should be avoided. Help child develop emotional regulation skills. Psychotherapy, behavioral therapy may help children with severe emotional distress. So, counseling and all that. Treatment of coexisting condition and deficiency anemia is associated with breath holding speed. Feeling sleepy. Drug therapy. Medications are not recommended because it's mainly a behavioral problem. It requires behavioral solutions. In severe cases, frequent episodes, atropine or pacemaker therapy may be considered. Yeah, so this one is done. Next one, temper tantrums. Frustration defines emotional outbursts in young children, and when they are unable to express their autonomy. These involve crying, kicking, hitting, pushing, throwing objects, headbanging. So anything and everything. They do anything and everything when their demands are not fulfilled. Demands are not met. Age of occurrence 18 months to 3 years. 18 months and 3 years. Peak occurrence 2 years to 3 years. Gradually subsides by 3 to 6 years as children learn to regulate their emotions. 3 to 6 years. Okay. I doubt they are able to. They can regulate the emotions, but fine, 3 to 6 years. But peak incidence between 2 to 3 years. Causes, yeah, they don't do that when they are old. That's right. Causes and triggers. I'm half asleep. I'm half feeling asleep, and I'm not able to use my 100% of my cognitive functioning. I feel like I need to go to sleep, but I'll finish this. I'll see how far I want to see how far we can go. That is the primary aim of this. Is it study with me? Study with me is in the silent mode, but this is completely different. This is, I could call it partly a streaming teaching Feynman method of study with me. Anyways, coming back. Developing autonomy. Child wants independence but lacks the ability to fully express it. Yeah, that is negativism. My child may do opposite of what they are told. Interesting. Separation from caregivers leads to emotional distress. Frustration due to unmet needs. Hunger, fatigue or overstimulation can worsen. Inability to communicate desires properly. Okay. Developing autonomy. If it is missing, negativism, positive, whatever is told, opposite of the separation from caregivers. Frustration due to unmet needs. Next, coming to management of treatment, anticipation and prevention. Recognize the triggers. So preventable triggers like hunger, tiredness, overstimulation. Avoid the situations altogether. Yeah. Avoid the triggers, avoid the situations in the first place. Give choices, avoid the allow the child to feel some control. Distraction and redirection, shift the child's attention to another activity. Okay. Change the environment of the child if the child is overwhelmed. Timeout technique. What is timeout? Remove the child from situation for 1 to 5 minutes. After timeout, reintegrate with hugs and reassurance. It's a manipulation. It's complete manipulation. Yeah. It's fine. It's a child. Reinforce positive behavior. Praise good behavior instead of focusing on tantrums. Yeah, most children outgrow tantrums. What age is it? Peak incident 2 to 3 years. Normal by, like, it reduces by 3 years after 3 years. Intensity percent by beyond 6 years. Yes, 3 to 6 years. By the time that happens, it reduces. For further evaluation, where is it? Yes, 3 to 6. Closing this. Next one, definition. persistent craving, compulsive eating of non-nutritive, non-edible substances for at least 1 month. Non-nutritive, non-edible substances is most commonly observed in children under 5 years of age, but can also occur in older children, individuals with intellectual disabilities. 5 years, common among 5 years, under 5-year-old. Commonly ingested substance: geophagia, pagophagia, other substances. Geo meaning earth, soil, clay, chalk, charcoal, earth or paint. Pago meaning ice, fine. Can you do normal people, normal adults sometimes eat ice? Non-edible substances, ice. Compulsive, it's not compulsive, yes, it's not compulsive. Other substance: dust, paper, soap, hair, ash, starch. So causes, nutritional causes, it could be biological, psychological, social, variety of factors. So first one, we have nutritional: iron deficiency, anemia, zinc deficiency, vitamin and micronutrients specifically not required. Psychological and behavioral cues, behavioral retardation, autism. Psychosocial stress seen in children with maternal deprivation, parental neglect or abuse. Trichotillomania, trichobazar, eating hair due to compulsive hair pulling. Clinical associations: lead poisoning, parasitic infections, iron deficiency, anemia, same thing. Next, pseudotumor cerebri associated with long-term pica behavior. So lead, iron deficiency, parasitic infections, yes. Pseudotumor cerebri. Complications: intestinal obstruction with inedible substances, lead toxicity, paint or contaminated soil, parasitic infections, contaminated substances. Parasitic infections, did I say parasitic substances? Parasitic infections from ingesting contaminated substances, GI perforation due to sharp, it's inedible, dental erosion. Diagnosis of pica: diagnosis is clinical based on history, physical examination, lab findings. History is non-nutritive eating for at least 1 month. Okay, it's compulsive. What was the definition again? It's a persistent craving and persistent craving and compulsive eating of what is happening. Craving, compulsive eating non-edible substances. Going down. Yes. Yeah, physical analysis for pallor. So what did we finish? We finished clinical association, etiology is done. What was it? First it was the what do you eat, those were the things, and what causes you to eat. Next one, what pica is associated with. So you may think of it as a behavioral problem, but it has some clinical association. So that was the another thing. Next one was complications, what could come up, and we are still in that. Parasitic infections, no, we are done with that. Dental erosion, did we? No, we didn't. Okay. Dental erosion from chalk or clay, abrasive substances. Then history is done. This is for pallor, anemia, lead toxicity, nutritional deficiencies. Lab investigation: CBC, iron, serum iron, ferritin levels, lead levels, exposure is suspected, stool examination to prevent parasitic infections. Next, coming to management, treatment, address nutritional deficiency. So nutritional deficiency, even the previous one, which one was it? One of the topics where nutrition was the first one, rest were behavioral. Which was the topic? Yes, was development. Oh yeah, which on some previous where it was related to food and supplementation, because zinc deficiency can also multivitamin. And iron, how much do you give? 3 gram milligram per kg per day. I I don't like doses. I don't know how long this thing I'm going to be taking this study with me thing, because is it even can I even cover these topics? Like how many? See, we are almost fourth. Adolescence. This one is skippable actually because I have not yet. I need to add it. I'll add it in the future. I'll see as fast as I can, as early as I can. Next, environmental modifications. Avoid exposure to lead-based paints and contaminated soil. Improve sanitation to prevent ingestion of harmful substances. Where we skipped the second one. Behavioral and psychological and parental education. Positive reinforcement. CBT. Okay. Environmental modification. Avoid exposure to lead-based paints and contaminated soil. Lead-based paints, yeah, because lead was it's a clinical association. It's coming to improve sanitation to prevent ingestion of harmful substances. Treatment of underlying conditions with psychotherapy, deworming therapy. Yeah. So most children and overgrow pica by early adulthood if underlying causes addressed. Long-term complications could include nutritional deficiencies, toxicity, GI disorders. It's coming to fluid and electrolyte imbalance. This SMR, I'll try to find it. I think I saw it somewhere. I didn't. It was difficult the other day because I was repeatedly. The goal was to finish this off before I go in depth learning. So I didn't. SMR. Yeah, sexual maturity rating. Here, yeah, in this particular book, let's see if there are more SMR, sexual maturity rating. Yeah, in this particular book, there are just few points. Probably I need to refer to some other book or get it from ChatGPT or something. Maybe a different book. Now that I'm doing this like slowly, better to get some nice. You have a lot of points with thicker books. You can't find those points with smaller ones. Yeah, SMR stage should be SMR stage height spot during lecture. No, this doesn't say anything in specific. That's why I marked it red. Yeah, it's fine. We'll go to hyperkalemia. Specifically, this is about management because that was asked repeatedly. Hyperkalemia is defined as potential greater than 5.5 milliequivalents per liter. It's a medical emergency. So this hyperkalemia and hypokalemia is there. It is repeated even in surgery, even in I think even in medicine. I'm not particularly sure of medicine, but surgery it is there. Both are there, hyper and hypo. Anyways, it can cause life-threatening arrhythmias, neuromuscular dysfunction. Acute hyperkalemia is poorly tolerated compared to chronic hyper. So acute is worse than chronic. Same right with heart failure also. Acute is worse. Like chronic means you have developed some kind of compensatory mechanisms. That's why you are sustaining. Acute is like out of nowhere. Goal of management. The management, three main principles: stabilizing cardiac membrane, because arrhythmias are really common. Now you need to prevent that. Second, shifting potassium from ECF to ICF, because ICF has more of potassium normally, but in this condition more of the proportional, it's more about proportional increase in potassium in ECF rather than in ICF, eliminating excess potassium from the body. Okay, so whatever is there, you from ECF it should reduce. Stepwise approach to treatment. Immediate measures: stabilization of cardiac membrane, intravenous calcium gluconate. So IV calcium gluconate 0.5 to 1 milligram per kg ml per kg. IV slow infusion over 10 minutes with 5% dextrose. Mechanism: does not lower potassium, stabilize cardiac myocytes, reducing arrhythmic risk. This has something to do with the positive. This thing stabilizes cardiac myocytes, reducing arrhythmic risk. ECG changes: peak T waves, QRS widening. Repeat ECG if ECG changes persist. Peak T waves, QRS widening. So these are the key points for hyperkalemia. Peak T waves, lot of potassium, just peaking the T wave. QRS widening, rapid shift of potassium from ECF to ICF. So we have managed the cardiac membrane. Next is coming to shifting from ECF to ICF. Let's see, insulin and glucose infusion, sodium bicarbonate infusion, nebulized salbutamol. Regular insulin 0.1 to 0.2, which how much was this one? 0.5 to 1. So 0.1 to 0.2 units per kg IV with 0.5. What is this? Yeah, it is doses are always confusing. So this glucose and this value both are same, but this is ml, this is in ml, this is in grams. 0.5 to 1, this is 0.5 to 1, fine. 0.1 to 0.2 is that is insulin. Insulin drives potassium into cells via sodium potassium ATPase. Monitor for hypoglycemia. So that is an always an issue. That's why you are giving glucose, right? Next is sodium bicarbonate solution. IV infusion 1 to 2 ml over 10 minutes. Mechanism: alkalosis shift potassium intracellularly. Indications: acidosis with hyperkalemia. So bicarbonate always it is more of like to compensate for the acidosis, you give bicarbonate. Like similar function in this one, but ketoacidosis. Nebulized salbutamol beta 2 agonist. Standard asthma dose can be repeated hourly. And what is the dose? Can't recall. Asthma dose for should I say? Yeah, let's test the functionality of this site. Let's search for asthma. It's called asthma. It is asthma. So which one should we look at? Yeah, we need to look in pediatrics. Where was it? Yes, bronchial asthma. No, came back up. There's a lot more. We are just in the first section. I'm in the first section. Where is it? RS, yes, here. Bronchial asthma. What's the dose? Yeah, the thing was, I remember what happened. So the dose, I realized, at least for me, that doses are a big headache. So unless it's a specific disease condition like status asthmaticus, status epilepticus, management of diabetic ketoacidosis, something of that sort, where it is but doses are super important. Only in that particular condition I added the doses. Otherwise, I have skipped the doses except in case of medicine 1. Where is the infectious diseases in this one? Medicine, yeah, in that particular chapter, the HIV prophylaxis of opportunistic infection. There are so many unnecessary doses which are included. I think I need to take those off. So now I remember that. Yeah, anyways, 0.5 to 0.15 to 0.2. I take that as the value, but I won't add it here. Just writing it standard asthma dose should be enough. Mechanism activates sodium potassium. What is the number? 0.15 to 0.2. Activates sodium potassium pump, shifting the yeah, less effective in renal failure patients. Okay, see 3 things. One is insulin and glucose. Second one is sodium bicarbonate. Third one was beta 2 agonist, that is albuterol. And the numbers for glucose, it's similar to what is the calcium glucose. It's like 0.1 to 0.2. No, 0.5 to 1. That 0.1, 0.2 is this one. Regular insulin. Units per kg, that's gram per kg. Upper one is the units ml per kg. Sodium bicarbonate is 1 to 2 ml per kg over 10 minutes. Next, potassium elimination from the body. To permanently remove excess potassium, following methods are used. Loop diuretics, furosemide, 1 to 2 mg per kg IV. If renal function is normal, 1 to 2 mg per IV. This is potassium excretion. Potassium exchange resins. Yeah. Caxylate sodium polystyrene sulfonate, 1 gram per kg orally or rectally. Repeat 6 to 12 hours. Mechanism exchange. I personally would forget about this dose. I don't want doses right now. It's fine. It makes sense personally for me, at least, to know those doses, like know it in my head when I'm actually using it. But in this particular case, I just need to know the overall management. I don't want to learn the doses. I'll skip the doses. But in this case, we need to know, because this is an emergency case, so it's fine. I'll learn the dose. What is the point? 1 to 2 mg per kg IV. That's the dose. Potassium exchange resins. That's 1 gram per kg orally or rectally. 1 gram. Yeah, previous 1.1 to 1 to 2. Hemodialysis. Indication severe hyperkalemia. Normally meaning it was called hyperkalemia if it was 5.5 or above. Here it is 8. Then you do hemodialysis. Refractory medical therapy. Treating underlying causes. Stop potassium intake. Discontinue IV fluids containing potassium and potassium rich foods. Correct acidosis, treatment of okay. Renal failure, hemodialysis. Address endocrine causes. Hydrocortisone 10 mg per kg IV. Adrenal insufficiency. Okay, ECG monitor. ECG. Finally, I thought where it went. Here it is. So peak T waves, prolonged PR. 6.5 to 8. Loss of P. Widened QRS. ST elevation, escape rhythms. Then sine wave, ventricular fibrillation is also. Okay, this one. Yeah. Calcium gluconate is. It starts from here. Loop diuretic 1 to 2 furosemide. It's 1 gram per kg. 1 gram per kg, right? 1 gram per kg correct. Yes, this one is done. Next one, hypokalemia. Hypokalemia is defined as serum potassium less than 3.5. It is essential. So this one is basic role of potassium. Remember, resting RMP, neuromuscular function, cardiac activity. Severe hypokalemia less than 2.5, literally life threatening. Cardiac arrhythmia, so very high is also bad, low is also bad. Muscle paralysis, metabolic disturbance. Causes: a decreased intake, like basic, you are not eat properly. Anorexia nervosa, malnutrition, poor parental nutrition. Next, coming to increased potassium loss, extrarenal potassium loss, GI losses, diarrhea, laxative abuse, sweating. Diarrhea, laxative abuse, sweating. Okay, it's like GI loss. GI. What does sweating come under GI loss? I think it's a typo, a mistake. Sweating is not, it's obvious, sweating is not, doesn't come under that. Renal potassium loss with metabolic acidosis, renal tubular acidosis, diabetic ketoacidosis, uterosigmoidoscopy. RTA, DKA, uterosigmoidoscopy with metabolic acidosis. This here. So renal loss, extra renal loss. So I think removing this, I think this should include diarrhea and laxative abuse. So sweating should come separately. There's something happened there. Renal potassium loss with metabolic acidosis, renal tubular acidosis, diabetic ketoacidosis. I'm feeling really sleepy. Oh, it's fine, 12 minutes. With metabolic alkalosis, normal or low blood pressure, vomiting, nasogastric tube suction. So renal loss happening with metabolic acidosis, metabolic alkalosis. If it is acidosis, renal tubular ketoacidosis, uterosigmoidoscopy. Wait. Uterosigmoidoscopy, how does that happen? Uterosigmoidoscopy. Potassium loss. How when? Oh, okay. Uterosigmoidoscopy, uretero. Can't even read properly. Ureterosigmoidoscopy with metabolic alkalosis, normal or low blood pressure, vomiting, nasogastric tube suction, low for thiazide diuresis. Alkalosis, it could be low blood pressure, high blood pressure. Low is volume depletion, volume, vomiting, nasogastric tube suction, low diuretic, and Bartter syndrome, Gentleman syndrome, congenital salt wasting disorders. High blood pressure, renin secreting tumors, Conn syndrome, adrenal hyperplasia, Liddle syndrome. Transcellular shift, intercellular potassium movement. So classification, this was basically classification of the causes. So coming to okay, this is still, we are still in causes. Transcellular shift, intracellular potassium movement, alkalemia, hydrogen shifts out,
potassium enters. Intracellular insulin administration stimulates sodium potassium ATP, driving potassium into. So basically opposite of what we learnt in treatment of this one, the previous hyperkalemia. Beta 2 agonist refeeding syndrome. What is refeeding syndrome? Life-threatening metabolic disturbance that occurs when nutrients, especially carbohydrates, are introduced too quickly in malnourished. Okay, like increase insulin, and because of that potassium. This is the same thing. This can lead. This is the physiological version of that. Physiological, yes, physiological meaning. Yes, meaning similar mechanism. Hypokalemic periodic paralysis. Some genetic thyrotoxic periodic paralysis. Okay. Basically, these four are most logical and easier to remember. These two are like some names that you need to keep in mind. Pathophysiology: volume depletion, RAS activation, sodium absorption by ENaC, that is because of aldosterone or ADH, one of those, aldosterone or ADH. Potassium loss in the urine. So unless it is, so coming to diuretics, it's a different topic. Unless it's potassium sparing, it is potassium wasting. I think potassium sparing is that is rest of them I can't recall exactly. I think one of them, there is one more which saves potassium, but the major one is potassium sparing. No, only potassium sparing is that. I am diverting too much. Renal potassium wasting occurs in gentlemen, Barter, Fanconi. Beta 2 agonist shifting of that. Hypokalemia, potential digoxin toxicity, increasing cardiac excitability. Okay. Clinical features of hypokalemia: neuromuscular symptoms, muscle weakness, hypotonia, muscle cramps, paralysis, ascending even, muscle weakness, hypotonia, muscle cramps, paralytic ileus. Cardiac symptoms: bradycardia, arrhythmia, increased digoxin toxicity risk. This was somewhat interesting concept. This thing, digoxin blocks sodium potassium ATPase. Because of that, there is so potassium should normally, it is thrown out. No, it's normally what is it? It is normally thrown, but because of this, there is less of potassium inside, more of potassium on the outside. Something like that. Can't actually think properly right now. But since 7 minutes are remaining, I want to just getting the concepts in head. The headings, the main key points in head is more important. So in this particular thing, the main takeaway is specifically the classification of causes. Like there is renal loss, extra renal, so increased intake, decreased intake, that is obviously. Potassium loss renally, extra renally, and whenever there is renal, you have all the ABG, acidosis, alkalosis, and with respect to alkalosis also there is increased BP, normal BP, and increased BP is like usually with hormone related. Transcellular shift is mainly insulin mediated or some kind of alkalemia. This is different mechanism. This is like the treatment of the previous one. Pathophysiology, almost renal wasting, Bartter syndrome, so kidney disorders. Beta 2 agonist, same thing. So this one is done. This one is polyuria, polydipsia, nephrogenic diabetes insipidus. Urinary retention, impaired bladder function. ECG changes in hypokalemia: mild, moderate, severe. flattened inverted T waves in mild. So, there it was peak T waves, here it is flattered or inverted. Moderate 2.5 to 3, ST depression. So, there it was elevation, there prolonged PR. I think there also prolonged PR, right? I think it was prolonged PR. Prolonged PR, yes. There also you get prolonged PR, here also prolonged PR. Severe it is US, widened QRS, there also there is widened. So, treatment: stabilize the ABC, identify underlying cause and treat it. Potassium replacement therapy. So, mild it is oral potassium, the normal foods, orange juice, coconut water, KCl tablets, IV maintenance fluids, KCl, IV maintenance with KCl. Same thing if it is severe, which is less than 2.5, 2.5 to 3.5, 2.5 to 3, 3 to 3.5, but extremely severe is less than 2.5. IV KCl 0.3 to 0.5 milliequivalents per kg per hour under cardiac monitoring. Guidelines for IV potassium replacement: never administer undiluted IV KCl as bolus, risk of cardiac arrest. Use central line for rapid infusion if severe hypokalemia with arrhythmias. Maximum IV rate 10 to 20 milliequivalents per liter. First one makes sense. Use central line. So, just central line said rapid infusion. Maximum IV rate 10 to 20 for 40 per liter, but yeah, 10 to 20 milliequivalents per hour maximum. 0.3 to 0.5 under cardiac monitoring. Peripheral line 40 milliequivalents per hour is under central line. Monitor serum potassium every 12 hours. Treat underlying cause. At hypomagnesemia, magnesium deficiency worsens, is accompanying. Brothers for life. Stop potassium wasting drugs, diuretics, beta agonists, insulin overdose, manage metabolic acidosis, alkalosis. So, there we have seen in renal loss, acidosis, alkalosis, two different complications of untreated hypokalemia: life threatening arrhythmias, paralysis, respiratory failure, abdomyolysis due to severe weakness, worsening of digoxin toxicity, diabetic insipidus. So, that is how this thing ends. Wait a second, something I missed. No, nothing. Yeah, just fairly straightforward actually. Like in case you have in case you are well, you can concentrate properly. This going through this should be very quick. Protein energy malnutrition. It's a clinical syndrome caused by deficiency in protein, energy, vitamins and other essential nutrients required for normal protein, energy, vitamins and other essentials essential nutrients required for normal body function and organ maintenance. It commonly affects infants and young children, particularly in low income populations, leading to cause of growth retardation. It's a leading cause of growth retardation, immunosuppression, mortality. So, deficiency of almost everything. Protein, energy, it contains both. So, even vitamins is included in the definition and other essential nutrients required for normal functioning and organ maintenance. The rest is other part is the epidemiology. Etiology: decreased intake, medical causes, perinatal, neonatal. So, going back to perinatal, neonatal, social, environmental. The first one, inadequate, so less food. Why less food? Because less money. Food habits influenced by, so bad habits, same thing. These two are bad habits, included under bad habits, but that comes under which leads to poor intake. Oh, finally. So I think I'll stop this. So how many Pomodoro sessions are we done with? 3. So within 3 sessions, that is almost, let's count. So it's not actually 3 hours 22 minutes. Like how many minutes did we take as a break, and somewhere out of nowhere I disappeared. So that part is included here. So almost 3 hours. 3 hours. It's fine for 3 hours. This is good. It could have gone faster in case this was daytime. But is it finishing entire piece is doable. The rest of the subjects not particularly sure. So medicine is really huge. But these are like it's easy, you can finish it quick. Medicine both could finish it quick. Surgery too is the biggest one, and OBG, like personally for me it is OBG and peds. Rest of it I think doable. These I'll go slow too. I think a better thing would be, by the like whatever time that is available, trying to do more of OBG, obstetrics and gynec along with peds. So if I get like some kind of something like this, what I did right now, if I do something like that for ops and gynec and peds, it would be nice before I stop doing it, because I'll be busy after exams and all that. So I'll stop this session, and I'll update the tables, the developmental milestones. I already have it, I just need to put it, like organize it properly. So I'll stop the thing and go to sleep now. Not sure if I should upload this entirely or cut some parts. I'll upload it entirely, I'll see what happens. Anyways, YouTube has that editing feature where after uploading you can edit some parts. Hopefully it still works, otherwise I'm not sure. So this has become something, so this was not live streamed, so this is a real recorded content. So I've been talking to myself for last 3.5 hours. I'll see, but this is nice actually. I'm actually if I was doing this by myself, I would have missed some points or something, because I just read through, I don't say it out. I need to say it out. Only if I say it out, I know that this is something different that I need to pay attention to. Otherwise, I just miss out the thing, and it's very sad if I do that. So anyways, I'll try to finish, I'll try to do this every day. That is number 1, and from tomorrow hopefully more than 3 hours, because every day, per day, how many hours do I get? Around 8 hours of, even if I do 8 hours of sleep, and some extra time for other miscellaneous activities, I can get about 12 hours like dedicated for studies. Imagine if I do 12 hours of this channel will blow up. Maybe I should try it out. anyways, let's see. This was my first session, sorry, second session. First one is in the folder, won't be uploading it. This one I would be. So tell me, in case you like the way it goes, meaning hours together, try getting the live timestamps or something. It would be very difficult, but I'll see how it goes, like, because I have never uploaded such a long video. I've done the shorter ones, meaning 10 minutes or something, a lot of times, but meaning previously, long back. But over here it is this is very long. Yeah, so in case you like this particular way of going through topics, finishing up questions for the exam, just you can subscribe, and in case you actually liked it, you can write it in the comments in case you want me to change something, some positioning, or the way I like. I doubt I can change the way I speak, because this is long form and you need to speak in the way that comes naturally. You can't stay in what is the staged mode for more than an hour or something. So that's it. Okay, then bye bye, good night.